Skin rash in mononucleosis patients. Ampicillin. Ampicillin also causes diarrhea and pseudomembranous colitis. How do you treat a pregnant woman with group B strep? Ampicillin. Remember that interstitial nephritis can be caused by methicillin, but it's not used in humans. Nafcillin, on the other hand, causes neutropenia. Oxacillin is hepatotoxic. How do you treat acute mastitis, which is a breast abscess during breastfeeding? Well, acute mastitis is usually caused by Staph aureus infection, so you treat it with dicloxacillin and continued breastfeeding. Acute mastitis, dicloxacillin, and continued breastfeeding. What treats gram-negative rods Klebsiella, Pseudomonas, and Serratia? It starts with an A. Aztreonam. It also works on a different binding site than penicillin, so it doesn't cross-react with penicillin. But aztreonam has no activity against gram-positives or anaerobes. Aztreonam side effects there are 3 of them. One is elevated LFTs and GI upset and skin rash. Aztreonam is synergistic with aminoglycosides. Aztreonam is also resistant to beta-lactamases. If the patient is allergic to penicillin or renally insufficient and cannot tolerate aminoglycosides, then you give aztreonam. Carbapenems are imipenem, meropenem, ertapenem, doripenem. Imipenem, meropenem, ertapenem, doripenem. Imipenem is always given with celastin. With imipenem, the kill is lastin with cilastatin. Cilastatin inhibits renal dihydropeptidase 1, which would normally inactivate imipenem in the renal tubules. Carbapenem toxicities are GI distress, skin rash, and seizures at high plasma levels. So imipenem causes seizures. Things that cause seizures are imipenem, isoniazid monotherapy, clozapine, and bupropion. Once again, things that cause seizures are clozapine, isoniazid, bupropion, and imipenem. Imipenem is more likely to give seizures in renally insufficient patients. With cephalosporins, there are 4 main side effects: hypersensitivity reaction, low vitamin K, so hypovitaminosis of vitamin K at high doses. They also will increase aminoglycosides nephrotoxicity. And then the 4th side effect is a disulfiram-like reaction with ethanol. And there's 3 cephalosporins that cause it: cefamidol, cefotetan, and cefoperazone. Other things that cause disulfam reactions are metronidazole, griseofulvin, procarbazine, and first-generation sulfonylureas like tolbutamide and chlorpramide. So that's metronidazole, griseofulvin, procarbazine, tolbutamide, chlorpropamide, cefamidol, cefotetan, cefoperazone. First-generation cephalosporins are cefazolin, cefadroxil, and cephalexin. Cefazolin, cefadroxil, cephalexin. They treat the PEK. They treat PEK, Proteus mirabilis, Escherichia coli, Klebsiella. Proteus, E. coli, Klebsiella. That's first-gen cephalosporins. They are all gram-negative. Proteus, E. coli, Klebsiella. That's first-generation cephalosporins. Now the things that second-generation cephalosporins treat, it's the henpex mnemonic. Henpeks. Henpex. Haemophilus influenza, Enterobacter for E, and then Neisseria for N, Proteus mirabilis for P, E. coli for E, Klebsiella for K, and Serratia for S. Henpex. H. influenza, Enterobacter, Neisseria, Proteus, E. coli, Klebsiella, Serratia. And the second generation names are cefoxitin, cefaclor, cefuroxime, and cefotetan, and cefprozil. So the second generation cephalosporins are also effective against H. influenza, Enterobacter, Neisseria, and Serratia. Third and fourth generation, think Pseudomonas. The two ones in particular are ceftazidime and cefepime. For remembering the bacteria that are resistant to cephalosporins, it's the LAME mnemonic, L-A-M-E, LAME. L, Listeria. A, atypical bacteria, Mycoplasma and Chlamydia. M, MRSA. E, Enterococcus, not Enterobacter. Enterobacter is treated by second-generation cephalosporins. It's Enterococcus. So, LAME. Listeria, Mycoplasma chlamydia for the atypicals, MRSA, and Enterococcus for resistant. Aminoglycosides need oxygen for uptake, so you can't use them against anaerobes. You can only use them against aerobes. Aminoglycosides are gentamicin, neomycin, amikacin, tobramycin, and streptomycin. Aminoglycosides inhibit the formation of the initiation complex and cause mRNA misreading. Aminoglycosides cause mRNA misreading. You use aminoglycosides for gram-negative rods, especially Pseudomonas. Streptomycin in particular is used for treating TB as well as tularemia. So streptomycin, think it treats two diseases, both begin with a T. Streptomycin, T. Tuberculosis and tularemia. Think 4 side effects with aminoglycosides: kidney, ears, teratogen, and neuromuscular blockade. They cause acute tubular necrosis, ototoxicity, which leads to deafness, birth defects, so it's a teratogen, and neuromuscular blockade. Aminoglycosides. You might also see vertigo and nausea and vomiting for aminoglycosides. Vertigo would sort of go with the ototoxicity, and then also just nausea and vomiting. Resistance to aminoglycosides can happen via 3 mechanisms: acetylation, phosphorylation, and adenylation. Acetylation is when you have an acetyl group going on to an amino group. But phosphorylation and adenylation are when you have either a phosphotransferase putting a phosphate group or an adenyltransferase putting an ATP-dependent adenylation. Both of those are on hydroxyl groups. So phosphorylation and adenylation, it's hydroxyl group, and acetylation is on a amino group, sorry. These enzymes that modify and inactivate aminoglycosides, they are called transferase enzymes, and they are found on plasmids and transposons. So plasmids and transposons will inactivate aminoglycosides by producing acetyltransferases, adenyltransferases, and phosphonotransferases. Now for clindamycin, remember that clindamycin along with macrolides inhibit translocation of the aminoacyl peptide during protein synthesis in the 50S subunit. Translocation, clindamycin and macrolides. How do you treat aspiration pneumonia? Clindamycin. How do you treat lung abscess? Clindamycin. How do you treat Gardnerella vaginalis? Clindamycin or metronidazole. Clindamycin is for anaerobes below the diaphragm. Although in lung abscess and aspiration pneumonia, I guess that would be above. No, never mind. For aspiration pneumonia, it would be above the diaphragm, but you use clindamycin anyway. And for lung abscess, you'll see air fluid levels. You treat that with clindamycin. If you see Gardnerella vaginalis, clindamycin. Clindamycin also has activity against MRSA, Clostridium perfringens, Bacteroides, and Group A strep. Impaired liver function, skin rashes like Stevenson-Johnson, nausea, and diarrhea. These are side effects of clindamycin. Liver function, skin rashes, nausea, diarrhea, and pseudomembranous colitis. Translocation of the aminoacyl peptide. Clindamycin and macrolides inhibit this. Dental abscesses can also be treated with clindamycin. Correction, clindamycin is above the diaphragm. Metronidazole is below the diaphragm. Going back to aminoglycosides, there are some other things. So it's contraindicated in pregnancy because it's a teratogen. But for the neuromuscular blockade, that results in respiratory paralysis. So watch out if the patient has myasthenia gravis or they're on neuromuscular blocking agents. You would never give them aminoglycosides. Myasthenia gravis, neuromuscular blockade, do not give aminoglycosides because it causes respiratory paralysis, a side effect of the neuromuscular blockade. Also, you would never give aminoglycoside patients penicillin in the same IV. Also, aminoglycosides have a sort of peak and trough effect because each patient has different levels of them, of aminoglycoside levels. For chloramphenicol, it inhibits the peptidyltransferase on the 50S subunit. Peptidyltransferase is the enzyme responsible for adding amino acids to the growing peptide chain. So chloramphenicol inhibits peptidyltransferase. And it's reversible. It reversibly binds the 50S subunit. Chloramphenicol treating, what it treats, think meningitis, 3 of them in particular, H. influenza, Neisseria meningitis, and strep pneumonia. This is the SHIN mnemonic for chloramphenicol. SHIN, strep pneumonia, H. influenza, Neisseria meningitis. What are the side effects for chloramphenicol? Gray baby syndrome, dose-dependent anemia. This is normocytic normachromic anemia for chloramphenicol. So GI upset, myelosuppression, which causes anemia, and gray baby syndrome, which is a lack of UDP glucuronyl transferase. Resistance to chloramphenicol is similar to resistance for aminoglycosides. The resistance is a plasmid-encoded acetyltransferase that attaches to the hydroxyl group of the chloramphenicol. Remember that it is plasmid-encoded. Now for macrolides. Macrolides, just like clindamycin, irreversibly bind the 50S ribosomal subunit, inhibiting the formation of the initiation complex, inhibiting translocation of the aminoacyl peptide. For what they treat, think especially chlamydia and diphtheria, then a lot of other things. Macrolide side effects. Okay, what if a patient has QT prolongation that can lead to torsade de pointes, diarrhea caused by motilin, cholestatic hepatitis with elevated alkaline phosphate, elevated bilirubin, elevated hepatic transaminases, peripheral eosinophils or eosinophilia, and a skin rash. Macroglide side effects. So QT prolongation, that leads to torsade de pointes, diarrhea, hepatitis, eosinophilia, and skin rash. Also, tacrolimus and sirolimus are macrolides. Tetracycline blocks the aminoacyl tRNA from binding to the ribosome. Blocks binding. Tetracycline blocks binding. Blocks the aminoacyl tRNA from binding to the ribosome. Just like macroglides are good for chlamydia, so are tetracyclines. Also, Rocky Mountain spotted fever, Lyme disease, Also, H. pylori, tularemia, and brucellosis. Remember that tetracyclines have limited CNS penetration, so they don't get into the brain. Tetracyclines have limited CNS penetration. You should not take tetracyclines with divalent cations because they inhibit absorption of tetracycline. Since doxycycline is fecally eliminated, you can use it in renal failure patients. Doxycycline fecally eliminated, you can use in renal failure patients. Resistance to tetracyclines are caused by efflux or reduced influx, and this is a plasmid-encoded resistance mechanism. Also, there's another one. There's a protein that can alter the binding of tetracycline to the 30S subunit, and and tetracycline blocks aminoacyl tRNA from binding to the ribosome. Side effects of tetracycline: GI upset, liver toxicity, bone deformity in children, so it's contraindicated in pregnancy, causes Fanconi syndrome, which is aminoaciduria, phosphaturia, acidosis, and glycosuria. So, glucose in the urine, acidosis in the blood, amino acids in the urine, glucose and amino acids in the urine, and phosphates in the urine as well. 3 things in the urine: glucose, amino acids, and phosphate. That's a side effect that's caused by Fanconi syndrome. Also, photosensitivity and dizziness are side effects of tetracycline. Dimeclocycline it acts at V2 receptors. It's a competitive antagonist, and it treats SIADH. Dimeclocycline, competitive antagonist at V2 receptors, treats SIADH. Moving on. Dihydropteroate synthase. Sulfamethoxazole inhibits this. It's a structural analog of PABA. Sulfamethoxazole, structural analog of PABA, inhibits competitively dihydropteroate synthase. That's the first step. And it's given with trimethoprim or TMP. Trimethoprim inhibits folic acid synthesis by inhibiting dihydrofolate reductase. So remember that the first step is blocked by sulfamethoxazole. The second step is blocked by trimethoprim. First step is dihydropteroate synthase. Second step is dihydrofolate reductase. Remember that Bactrim is bacteriostatic. Bactrim is bacteriostatic. So the second step, the trimethoprim step, it can be bypassed with leucovorin. This is important because Bactrim can cause hemolytic anemia and granulocytopenia, which is alleviated with folinic acid supplementation and leucovorin. Bactrim can also cause kernicterus in newborns. So if you have a newborn with kernicterus, it might be caused by Bactrim or trimethoprim sulfamethoxazole. TMP SMX also treats nocardia, pneumocystis jirovecii, UTIs, that's important. It also treats Salmonella and Shigella. So E. coli, Enterobacter, Klebsiella, Salmonella, Shigella, nocardia, pneumocystis jirovecii, UTIs. And ocular chlamydial infections. Side effects of Bactrim are the hemolytic anemia, kernicterus in newborns, and Stevenson-Johnson syndrome. The Stevenson-Johnson syndrome is because sulfamethoxazole is a sulfonamide, and all sulfa drugs cause Stevenson-Johnson syndrome. And another addition, you can also treat toxoplasma with Bactrim, trimethoprim, sulfamethoxazole. So if you have a CD4 count of below 200 or below 100, then you use Bactrim. But if it's below 50, then you're worried about something else. You're worried about Mycobacterium avium, and you treat that with azithromycin. Another concern with Bactrim is kidney stuff. You're worried about renal interstitial infiltration and also drug-induced tubular obstruction. It's the acute type of renal interstitial infiltration for Bactrim. So here are the things that can cause renal interstitial infiltration. There's the acute type and the chronic type. The acute type is 1, 2, 3, 4, 5, 6 things. The first thing is acetazolamides. Second thing is allopurinol. Third thing is cephalosporins. Fourth thing is methicillin. And fifth thing is NSAIDs. And then sixth thing is sulfonamides and trimethoprim. So Bactrim, acute type. Now for what causes chronic renal interstitial infiltration is lithium and cyclosporin. So chronic is lithium and cyclosporin. Acute is 6 things: allopurinol, acetazolamides, cephalosporin, methicillin, sulfonamides and trimethoprim, and NSAIDs. And then chronic is lithium and cyclosporine. So when I said that trimethoprim inhibits dihydrofolate reductase, that's only in prokaryotes. For eukaryotes, it's methotrexate that inhibits dihydrofolate reductase. Bactrim is bactericidal, although sulfonamides alone are just bacteriostatic. Fluoroquinolones, ciprofloxacin especially. Side effects are GI upset, skin rash, headache, dizziness, tendinitis and tendon rupture in adults, often described as tenderness in the elbow and knee joints. It also causes phototoxicity and seizures. All the medications that have seizure as a side effect: ciprofloxacin, bupropion, clozapine, isoniazid if given without vitamin B6, pyridoxine, imipenem, carbapenem, which is a carbapenem. So the things that cause seizure side effects, what starts with a B? Bupropion. Starts with a C? Well, there are 2 of them. Ciprofloxacin and clozapine. Starts with an I? Well, there are 2 of them. Isoniazid if not given with vitamin B6. And imipenem. Those are the things that cause seizure side effects. 6 things. Or 5 things. So what are the contraindications of ciprofloxacin or fluoroquinolones? You don't give them to 3 kinds of patients: pregnancy, children, or myasthenia gravis patients. You don't give aminoglycosides to myasthenia gravis patients either. Fluoroquinolones cause myalgia in children. Fluoroquinolones inhibit DNA topoisomerase 2 and DNA gyrase. This effectively induces DNA strand breakage and cell death. So it's DNA topoisomerase 2 and DNA gyrase. Fluoroquinolones can also cause leg cramps and, I already said, myalgias. So that's fluoroquinolones, leg cramps, myalgias. And some may also cause prolonged QT interval. So it seems that both macrolides and fluoroquinolones can cause increased QT interval. If the patient is above 60 years old or they're taking glucocorticoids like prednisone, then it can cause tendon rupture. So watch out for glucocorticoids and fluoroquinolones together. And the things that cause resistance for fluoroquinolones, there are 3 kinds. There is a chromosome-encoded mutation in DNA gyrase. There is plasma-mediated resistance, and there are efflux pumps. So mutation in DNA gyrase done by the chromosome. Then there's also plasmid stuff and efflux pumps. For what fluoroquinolones treat, think UTIs, GI infections, respiratory tract infections like pneumonias, gonococcal infections, and meningococcal infections in adults. But if it's in children, if it's a meningococcal infection in children, you use rifampin. When you're giving fluoroquinolones, you want to use a slow IV infusion. Also, you want to avoid milk products or antacids, as calcium and antacids form chelating complexes with fluoroquinolones, and this prevents drug absorption. Also, if it's an anaerobic infection, ciprofloxacin is not effective against anaerobes. Vancomycin binds transglycosylase inhibiting diala terminus. Transglycosylase for vancomycin. Treats MRSA, staph epidermis, and just gram-positive bacteria. For side effects, think 4 main things: thrombophlebitis, which is inflammation of veins that have clots in them. Ototoxicity and nephrotoxicity are 2 big ones for vancomycin. It also causes red man syndrome, histamine release, which is prevented by slow IV infusion and giving antihistamines. So ototoxicity and nephrotoxicity for vancomycin. So for treating MRSA, remember there are 5 medications: vancomycin, daptomycin, linezolid, which can cause serotonin syndrome, tigecycline, and ceftaroline. And then for vancomycin-resistant enterococcus, it's linezolid and streptogramins, which are quinupristin and dalfapristin. Vancomycin also treats Clostridium difficile pseudomembranous colitis. And something you'll see commonly with vancomycin is facial flushing. So the things that can cause facial flushing are vancomycin, niacin, calcium channel blockers, and there's 3 of them in this case: verapamil, diltiazem, and nifedipine. And adenosine is the 4th thing that can cause facial flushing. Resistance to vancomycin happens when the cell wall is changed from diala to diala-D-lac, preventing binding of vancomycin. Also, a side note, Thayer-Martin agar will have vancomycin and polymyxin on it, and nystatin. So that would inhibit gram-negative organisms except Neisseria, and nystatin inhibits fungi, and vancomycin inhibits gram-positive organisms. So what would grow in the Thayer-Martin agar is gonorrhea and meningitis, both Neisserias. Metronidazole. It causes, it's metabolized by bacterial proteins into reduced reactive compounds that damage bacterial DNA, proteins, and membranes. Side effects of metronidazole: headache, metallic taste, disulfiram-like effect with alcohol, and it's also contraindicated in pregnancy. There are 12 drugs that are contraindicated in pregnancy. Countless safe moms take really good care. Countless. Clarithromycin, so that's macroglides. Safe, sulfonamides. Moms, metronidazole. Take, tetracycline. Really, ribavirin. Good, griseofulvin. Care, chloramphenicol. And then also ACE inhibitors, which cause fetal renal agenesis or whatever, or aminoglycosides, atorvastatin, fluoroquinolones, and warfarin. So that's clarithromycin, sulfonamides, metronidazole, tetracycline, ribavirin, griseofulvin, chloramphenicol, ACE inhibitors, aminoglycosides, atorvastatin, fluoroquinolones, and warfarin. Something of interest: metronidazole actually potentiates the actions of anticoagulant drugs such as warfarin. So metronidazole will potentiate warfarin. Other side effects of metronidazole are it has neurological side effects, paresthesia and dizziness, and also causes nausea, vomiting, and crampy abdominal pain. So the side effects of metronidazole: headache and neurologic, paresthesias, dizziness, metallic taste, and disulfiram-like reaction, and nausea and vomiting and crampy abdominal pain. Rifampin. Think of the ref peeing on the H influenza B guy. And it also treats meningitis and leprosy, and it has red-orange urine. This could be because rifampin causes acute intermittent porphyria. Other things that cause acute intermittent porphyria are barbiturates, anti-epileptics, metoclopramide, and rifampin. Rifampin can also cause interstitial nephritis. Things that cause interstitial nephritis: beta-lactams, sulfonamides, trimethoprim, NSAIDs, ACE inhibitors, diuretics, and rifampin. These are all things that cause interstitial nephritis. Rifampin inhibits the beta subunit of DNA-dependent RNA polymerase. So it leads to decreased mRNA synthesis in bacterial cells. Once again, rifampin inhibits DNA-dependent RNA polymerase, the beta subunit of it, and that causes decreased mRNA. Rifampin treats tuberculosis, leprosy, and Mycobacterium avium complex. So those three things: TB, leprosy, and MAC for rifampin. Also H influenza type B and Neisseria. Side effects of rifampin: the orange color urine, and sweat and rash and thrombocytopenia, so low platelets for rifampin, and nephritis, I already went over that, and hepatitis, that's a big one. Rifampin causes hepatitis. Also, to treat MAC, you use 3 drugs: azithromycin, ethambutol, and rifampin. That's to treat MAC: azithromycin, ethambutol, and rifampin. Isoniazid inhibits the synthesis of mycolic acids. Isoniazid inhibits the synthesis of mycolic acids. It's the only TB monotherapy that there is, isoniazid. Side effects of isoniazid are peripheral neuropathy from vitamin B6 deficiency, drug-induced lupus, hepatitis, high anion gap metabolic acidosis, and G6PD deficient hemolytic anemia. So there are 2 kinds of anemia that isoniazid can cause: sideroblastic anemia and G6PD hemolytic anemia. Here are all the things that can cause sideroblastic anemia: isoniazid, chloramphenicol, linezolid, alcohol, lead poisoning, copper deficiency. Now here are all the things that can cause G6PD hemolytic anemia: isoniazid, sulfonamides, primaquine, NSAIDs, and nitrofurantoin. Those are the 5 things that can cause G6PD anemia: isoniazid, sulfonamides, primaquine, NSAIDs, and nitrofurantoin. Sideroblastic anemia, on the other hand, is isoniazid, chloramphenicol, linezolid, alcohol, lead, and then copper deficiency. So if the patient has a positive PPD, then you treat it with isoniazid, the isonite. In patients who are slow acetylators of isoniazid, they have increased neuropathy, also a side effect of isoniazid, increased bladder cancer, and familial Parkinson disease. The enzyme that acetylates isoniazid is N-acetyltransferase. Another drug that can cause G6PD anemia is dapsone. G6PD hemolytic anemia, dapsone. Dapsone antagonizes PABA, P-A-B-A, and it inhibits folic acid synthesis, similar to sulfonamides. So dapsone antagonizes PABA. Dapsone is also prophylactic against pneumocystis jirovecii in HIV patients. Side effects of dapsone: causes G6PD deficient hemolytic anemia, GI intolerance, so nausea and vomiting. It causes a rash. That's right, dapsone causes a rash. And it also causes agranulocytosis. Dapsone causes agranulocytosis. And dapsone also causes methemoglobinemia. Dapsone causes methemoglobinemia. Pyrazinamide side effects: hyperuricemia, which causes gout, and hepatotoxicity. So that's liver and hyperuricemia. So you might see liver problems and gout with pyrazinamide. What are the side effects of nucleoside reverse transcriptase inhibitors, NRTIs? For zidovudine, it is neutropenia and megaloblastic anemia. So zidovudine, neutropenia, megaloblastic anemia. For didanosine, it is pancreatitis. Didanosine, pancreatitis. For zalcitabine and stavudine, it's peripheral neuropathy. A common side effect is a rash. Abacavir can cause lactic acidosis. Abacavir, lactic acidosis. For mothers who are HIV positive, you use zidovudine, which is AZT, to reduce risk of viral transmission. NRTIs lack a 3' OH group, so the next nucleotide can't be added. NRTs need to become activated by phosphorylation by the host cell. And NRTIs inhibit HIV reverse transcriptase. Thymidine kinase activates NRTIs by phosphorylating them before they can become functional. That's thymidine kinase. Didanosine, which is a guanosine analog, can cause pancreatitis, as well as peripheral neuropathy, bone marrow suppression, and lactic acidosis, and hepatic steatosis. That's didanosine. Abacavir, which causes lactic acidosis, is also a guanosine analog. So the guanosine analogs are zidovudine, which is AZT, didanosine, abacavir. The cytidine analogs, there are two of them. One begins with an L, one begins with an E. The first one is lamivudine, and the second one is emtricitabine. To sum up NRTI side effects, it's anemia, lactic acidosis, pancreatitis, neuropathy, and rash. And you treat the side effects you reverse the anemia with G-CSF and EPO. This also reverses the neutropenia and the megaloblastic anemia. Now the NNRTIs, they actually bind to the HIV reverse transcriptase and block DNA synthesis. Nevirapine side effects are Stevenson-Johnson syndrome, fulminant hepatitis. So that's nevirapine side effects. Now for delavirdine side effects, it causes headache, fatigue, nausea, and a rash, elevated LFTs, and it's also teratogenic. Now the last one, efavirenz, causes CNS disturbances including insomnia, dizziness, delusions, nightmares, and it also causes a rash. So all three NNRTIs cause a rash, but nevirapine causes Stevenson-Johnson rash. For liver symptoms, nevirapine and delavirdine have liver symptoms. Nevirapine causes fulminant hepatitis, so that's the worst for liver. And then delavirdine also causes elevated LFTs. For CNS symptoms, it's the last two. Delavirdine causes headache and fatigue, and efavirenz causes CNS disturbances, insomnia, dizziness, delusions, and nightmares. Patient has a rash, hepatitis, think nevirapine. Patient has a headache, fatigue, elevated LFTs. Mother gives birth to a deformed child. She has a rash and nausea. Think delavirdine. Patient has insomnia, dizziness, nightmares, or delusions, and a rash. Think efavirenz. HIV Pol gene mutations will give resistance to NNRTIs and protease inhibitors. That's NNRTIs and protease inhibitors. Pol gene gives resistance to these. Which NNRTIs are teratogenic, delavirdine, and efavirenz. Protease inhibitor side effects: hyperlipidemia, insulin resistance, altered distribution of body fat, so you see a buffalo hump, and increased truncal obesity. Ritonavir and nelfinavir and amprenavir can cause GI discomfort and paresthesia. So those are protease inhibitors. Ritonavir, nelfinavir, amprenavir, GI discomfort and paresthesias. And indinavir can cause elevated bilirubin levels, kidney stones, and proximal tubule injury, so nephrolithiasis, and hematuria. So to sum it up, protease inhibitors cause hyperglycemia and lipodystrophy, so it looks kind of like diabetes. You also get the insulin resistance that would make it look like diabetes. Acyclovir and ganciclovir are both guanosine analogs. So NRTIs must be activated by thymidine kinase. So the same thing with acyclovir. Acyclovir, it treats basically just herpes, HSV1, 2, and varicella-zoster virus, and EBV. So those 4 types of herpes is what's treated by acyclovir. Acyclovir is used to treat genital herpes, herpes encephalitis, oral hairy leukoplakia, which is caused by EBV, Epstein-Barr virus, and acute varicella virus. Acyclovir is similar to valacyclovir, pencyclovir, and famciclovir. If a virus lacks thymidine kinase, then acyclovir can't be activated, so the virus will be resistant to acyclovir if it lacks thymidine kinase. Acyclovir is weak against EBV, and it has no activity against CMV. That's acyclovir, no activity against CMV. If the herpes and ZVZ are latent, then it has no effect. Valacyclovir, it has better oral bioavailability than acyclovir. Famciclovir is better for VZV. Once again, famciclovir is better for VZV. Acyclovir can crystallize in the renal tubules and cause obstructive crystalline nephropathy and acute renal failure if they're not hydrated. So with acyclovir, hydrate the patient. Another side effect of acyclovir is neurotoxicity. It can cause tremors and delirium. So acyclovir causes neurotoxicity, tremors, and delirium. It also causes GI upset. It also causes headache. The oral acyclovir side effects are headache and GI distress. The IV acyclovir side effects are CNS toxicity and nephrotoxicity. With acyclovir, you might see increased BUN and increased creatinine. As far as the CNS toxicity goes, you might see myoclonus. Acyclovir is a chain terminator that requires thymidine kinase to activate. Remember that with treatment, you give daily doses of acyclovir. Ganciclovir is also an analog of guanosine, but it inhibits CMV DNA polymerase. after phosphorylation by viral kinase, thymidine kinase, into a nucleotide analog. Ganciclovir is used to treat CMV retinitis. AIDS patients are susceptible to CMV, so you use ganciclovir. For ganciclovir side effects, there are 4 of them: seizures, headache, but the main one is pancytopenia, so decreased RBCs, neutrophils, and white blood cells, and it's also nephrotoxic. So the 4 side effects of ganciclovir are pancytopenia, nephrotoxicity, seizures, and headache. So the 3 things that treat CMV retinitis are ganciclovir, foscarnet, and cidofovir. Foscarnet directly inhibits the DNA polymerase by binding to the pyrophosphate binding site. There are 2 times where you use foscarnet. One is in CMV retinitis when ganciclovir fails. The other is in acyclovir-resistant herpes simplex virus. Cidofovir is the exact same. And both foscarnet and cidofovir are nephrotoxic. A mechanism of resistance to foscarnet is mutated DNA polymerase. So both foscarnet and cidofovir are nephrotoxic. But with cidofovir, you can give probenecid and IV saline. It's probenecid and IV saline to reduce toxicity. What are the 2 drugs that inhibit the uncoating of the virus? Amantadine and rimantadine. Amantadine binds the M2 surface protein on influenza A, and that blocks uncoating. Also, amantadine has another side effect. It stimulates the release of dopamine from the nigra striatum. So you can use amantadine to treat influenza A, amantadine influenza A, and also Parkinson's disease. Amantadine and rimantadine have CNS side effects: ataxia, slurred speech, dizziness, and GI upset. So amantadine and rimantadine cause ataxia, slurred speech, and dizziness. Amantadine also can cause agitation, restlessness, psychosis, and urinary retention. So remember that amantadine has anticholinergic side effects. Amantadine also has orthostatic hypotension, dry mouth, nausea, vomiting, blurring of vision, visual hallucinations can be seen with amantadine. Amantadine increases the synthesis, release, and reuptake of dopamine. Now, what drug reduces intracellular GTP? Ribavirin. Ribavirin induces hypermutation in RNA viruses. It also inhibits inosine monophosphate dehydrogenase, so that depletes intracellular GTP. Remember that IMP can be converted to either AMP or GMP. So 2 drugs, ribavirin and mycophenolate, will inhibit the conversion from IMP to GMP. Mycophenolate and ribavirin block IMP to GMP by blocking IMP dehydrogenase. This inhibits guanosine synthesis. How do you treat hepatitis C? Ribavirin. How do you treat RSV? Ribavirin. And you can also use it for influenza A and B. For ribavirin, there are 3 side effects that are important: hemolytic anemia, elevated bilirubin levels, and it's also a teratogen. Ribavirin is incorporated into RNA base pairs guanosine and adenosine, causing hypermutations. Amphotericin, it binds ergosterol and creates pores. For Mucor and Cryptococcus especially, you use amphotericin B. You give amphotericin IV through IV, and when you give amphotericin through IV, that can cause fever, chills, muscle spasms, headache, and phlebitis. The big side effect with amphotericin B is nephrotoxicity. And it's also hepatotoxic. It causes abnormal LFTs. And it's also kind of cardiotoxic. It causes arrhythmias and hypotension. And it causes veins, vasoconstrictive, something like that, and also decreased potassium. So when you give amphotericin B, you give it with potassium and magnesium. And nystatin is the oral form of amphotericin B, and that's for candidiasis. Back to ribavirin real quickly. There are two more things. It causes defective 5' methyl cap formation on the mRNA transcripts. So that's another mechanism of ribavirin. And then back to amphotericin B again. You give it with liposomes, and you hydrate as well for amphotericin B. So nephrotoxicity, hypokalemia, and hypomagnesemia. Think amphotericin B toxicity. What does flucytosine get converted to? 5-FU, 5-fluorouracil, is what flucytosine gets converted to by cytosine deaminase in the fungal cell. When you have fungal meningitis caused by Cryptococcus, think flucytosine and amphotericin. So when flucytosine gets converted to 5-FU, 5-FU inhibits thymidylate synthetase. 5-FU inhibits thymidylate synthetase, thereby inhibiting fungal DNA and RNA synthesis. You also use flucytosine to treat candida. The biggest side effect for flucytosine is bone marrow suppression. It also is hepatotoxic with increased LFTs and some GI symptoms. Now for ketoconazole, miconazole, and clotrimazole. So ketoconazole and azoles treat blastomycosis, coccidioides, histoplasmosis, aspergillus, mucor, and candida. And it also treats Cushing syndrome and prostate cancer. So azoles also treat Cushing syndrome and prostate cancer. Remember that ketoconazole inhibits testosterone synthesis. When ketoconazole and azoles inhibit testosterone synthesis, this causes decreased libido, gynecomastia, and menstrual irregularities. And ketoconazole inhibits ergosterol synthase, so turning lanosterol into ergosterol. Don't confuse flucytosine with fluconazole. Fluconazole is also an azole, and both fluconazole and flucytosine treat cryptococcal meningitis and candidal sepsis. So cryptococcal meningitis, fluconazole and flucytosine. Wow, okay. Okay. Oh, and azoles also cause abnormal liver enzymes. Griseofulvin inhibits cell mitosis, disrupts mitotic spindles, binds tubulin. Griseofulvin. Griseofulvin works especially in keratin-rich tissues like skin, nails, hair. So epidermophyton, microsporum, and trichophyton treat that with griseofulvin, and it's oral. And it treats topical dermatophytic infections. Griseofulvin has like 5 or 6 side effects. They are headaches and confusion. Griseofulvin, headaches, confusion. GI upset, allergic reaction, hepatitis. So griseofulvin causes hepatitis. Griseofulvin is also teratogenic, and it causes photosensitivity. And the other medication that treats dermatophytic infections is terbinafine. Another quick thing, griseofulvin can also cause acute intermittent porphyria, along with phenobarbital and phenytoin. So that's acute intermittent porphyria caused by griseofulvin. Now for anti-malarials, chloroquine. Chloroquine inhibits heme polymerase. So you'll see a huge increase in heme in the plasmodium, and it won't have any hemozoin. So because heme polymerase converts heme to hemozoin, so with chloroquine you'll see increased heme. Chloroquine treats Vivax and Ovale. Vivax and Ovale. Side effects of chloroquine are blurred vision and visual disturbances, could be even described as night blindness, GI upset, pruritus, ECG changes such as increased QT. So chloroquine can cause an increased QT. So both class 3 antiarrhythmics and chloroquine apparently cause increased QT. And hydroxychloroquine treats rheumatoid arthritis. And a side effect of hydroxychloroquine is myopathy. Keep in mind that chloroquine does not treat Vivax or oval parasites that remain dormant in the liver, so you would have to use mefloquine or quinine. So just like chloroquine increases QT, quinine also increases QT because quinine is a class 1A antiarrhythmic. Watch out for torsade de pointes if it's quinine or quinidine related. How do you treat Plasmodium falciparum? You can use either quinine or mefloquine. Quinine treats both Plasmodium falciparum and Babesia microti. Mechanisms of quinine and mefloquine are unknown. Side effects of quinine: think cinchonism, which is disturbed vision, tinnitus, headache, dizziness, and nausea. Also, quinine can cause Combs-positive hemolytic anemia, and it's toxic to fetuses, so quinine would be a contraindication in pregnancy. Quinine also causes purpura and agranulocytosis, which goes with anemia. And the hemolytic anemia is G6PD related. So now mefloquine, which treats P. falciparum. It only has 3 side effects. The main one for mefloquine is mental status changes. It also causes GI upset and cardiac abnormalities for mefloquine. Another antimalarial is pyrimethamine. So methotrexate inhibits dihydrofolate reductase in humans. Trimethoprim or Bactrim, trimethoprim inhibits dihydrofolate reductase in bacteria, and pyrimethamine inhibits dihydrofolate reductase in protozoa. So all these will decrease TMP. Methotrexate, trimethoprim, pyrimethamine, decrease TMP by inhibiting dihydrofolate reductase. Pyrimethamine also treats Toxoplasma gondii when combined with sulfadiazine. Side effects of pyrimethamine: bone marrow suppression. Pyrimethamine, bone marrow suppression. Primaquine mechanism is unknown, but they might act as antioxidants. Oxidants. Primaquine is probably an oxidant, and it treats the hepatic forms of Vivax and Ovale. It does not treat the erythrocytic forms of Vivax and Ovale. It's primaquine. Causes hemolytic anemia in G6PD patients, and the other drug actually doesn't cause G6PD anemia. It's just primaquine. Primaquine also causes abdominal pain. Primaquine is contraindicated in pregnancy because it might cause hemolytic anemia in the fetus. So all the drugs that cause G6PD hemolysis are isoniazid, sulfonamides, dapsone, primaquine, aspirin, ibuprofen, nitrofurantoin. Now for pentamidine. How do you treat pneumocystis jirovecii? There are two drugs that treat it: pentamidine and Bactrim. And prophylaxis, there are two drugs that can prophylactically prevent pneumocystic jirovecii. That's dapsone and atovaquone. But to treat it, you need pentamidine or Bactrim. But pentamidine also treats another thing called African trypanosomiasis or Trypanosoma brucei and leishmaniasis. Pentamidine has 3 side effects, so even though it has a penta name, which would imply 5, it has 3 side effects. These side effects are nephrotoxicity, pancreatic damage, and cardiac arrhythmias. So pentamidine, think kidney, pancreas, heart. Nephrotoxicity, pancreatic damage, cardiac arrhythmias. What do you treat Trypanosoma cruzi or Chagas disease with? Nifurtimox. The mechanism of nifurtimox is oxygen radicals. Breaking down of the drug generates oxygen radicals. When you're treating Chagas disease, think about the side effects of nifurtimox, which are neuropathy, seizures, hypersensitivity, and GI upset. That's nifurtimox side effects. So now for Suramin. Suramin also treats, along with pentamidine. Pentamidine and Suramin treat Trypanosoma brucei, so African trypanosomiasis. And Suramin also treats onchocerca volvulus, but you'd use ivermectin for that. Side effects of Suramin: GI upset, neurologic disturbances, and renal abnormalities. So neuro and renal for Suramin. Neuro and renal for Suramin. But if the Trypanosoma brucei is in the CNS, then you use melarsoprol. So melarsoprol treats late Trypanosoma brucei infections, and both Suramin and melarsoprol have neuro side effects. Melarsoprol causes encephalopathy. And both Suramin and Melarsoprol also have renal abnormalities. They both cause renal damage. How do you treat leishmaniasis? Sodium stibogluconate. Sodium stibogluconate treats leishmaniasis. Side effects of sodium stibogluconate: GI upset, ECG changes, and cardiac arrhythmias. So with stibogluconate, think it treats leishmaniasis, but it causes cardiac arrhythmias. Ivermectin. Ivermectin activates GABA receptors, leading to worm paralysis and death. It treats onchocerca volvulus and strongyloides. So it treats river blindness. Ivermectin. Ivermectin side effects: it causes the Mazzotti reaction, which is 5 things. Mazzotti reaction is fever, rash, hypotension, arthralgias, and vertigo. So you'll feel like dizzy, you'll be arthritic, you'll have hypotension and rash and fever with ivermectin. Now for albendazole, mebendazole, and thiabendazole. They inhibit microtubule synthesis and function. So albendazole, mebendazole inhibits microtubule synthesis and function. They treat Necator and Xylostoma, whipworm, which is Trichuris, roundworm Ascaris, and pinworm Enterobius. Albendazole can also treat strongyloides, neurocysticercosis, hyatid disease, and cutaneous larva migrans, and trichinosis. They cause just GI upset and allergic reactions. Now, pyrantyl pamoate. Its mechanism is it activates parasitic nicotinic receptors on the worm, causing worm paralysis. So pyrantyl pamoate activates nicotine receptors. And it treats hookworm, roundworm, and pinworm. And side effects are GI upset. So it's like it's the second line drug for albendazole or whatever. Praziquantel increases calcium uptake, causing parasite contraction and paralysis. Treats schistosomiasis, neurocysticercosis, as well as hyatid disease and tania, and dibilothratum, whatever, latum, and clonorachis. Side effects of praziquantel are elevated LFTs and GI upset. So praziquantel is a little bit hepatotoxic. Don't confuse praziquantel with pyrantyl pamoate, which only causes GI upset. Okay, so then the last drug is niclosamide. It inhibits worm production of ATP. Niclosamide treats tapeworm infections, such as tania and D. latum. Side effects are GI upset. So, what activates GABA receptors? Ivermectin. What inhibits microtubule synthesis and function? Albendazole, mebendazole, thiabendazole. What increases calcium uptake? Praziquantel. What inhibits production of ATP? Niclosamide. What activates nicotinic receptors? Pyrantyl pamoate. Praziquantel increases calcium uptake. Pyrantyl pamoate activates nicotinic receptors. For side effects of bosentan, the mnemonic is HATE, H-A-T-E. Causes hepatotoxicity, anemia, so teratogen, and edema. Once again, bosentan, think hate. Hepatotoxicity, anemia, teratogen, and edema. Also remember that bosentan treats pulmonary arterial hypertension. First generation H1 blockers: diphenhydramine, dimenhydrinate, chlorpheniramine. Remember that they cause motion sickness and allergies, and they're a sleep aid. And the H1 blockers that are first gen are anti-adrenergic, as well as anti-muscarinic. So H1 blockers first gen, they both block muscarine receptors and alpha adrenergic receptors. Think A and M for H1 blockers. They block that. Remember that normal activation of H1 receptors causes contraction of smooth muscle, pruritus, and increased capillary permeability. So first-gen H1 blockers will cause bronchodilation, decreased pruritus, decreased resistance of the peripheral vasculature, decreased GI tract motility, and decreased rash formation. First-gen H1 blockers cross the CNS membrane. Second-generation H1 blockers do not cross the CNS membrane. So all of the first-generation H1 blockers are, promethazine, meclizine, hydroxyzine, doxylamine, diphenhydramine, dimenhydrinate, and chlorpheniramine. So, and the ones that are azines or amines are usually H1 blockers. Promethazine is used to treat is used as an antiemetic, and meclizine treats vertigo and motion sickness. Side effects of H1 blockers are dry mouth, blurry vision, and tremors. Thalidomide decreases TNF-alpha production, and it treats erythema nodosum leprae, which is, I think, leprosy, and also multiple myeloma. So thalidomide treats multiple myeloma and leprosy. Side effects besides the teratogenicity are deep vein thrombosis and sedation. So thalidomide, you're worried about deep vein thrombosis. For treating rheumatoid arthritis, inflammatory bowel disease, or psoriasis, think either infliximab or adalimumab. Infliximab also treats ankylosing spondylitis. Side effects of infliximab: just abnormal LFTs. Also can cause hypotension. But then there's another one. This one is important. Infliximab can cause reactivation of TB. Same thing with etanercept and adalimumab. They can all cause reactivation of TB. Calcipotriene, that treats psoriasis, activates a nuclear transcription factor. So calcipotriene, nuclear transcription factor. Big side effect of etanercept, besides reactivating latent TB, is etanercept can cause SLE syndrome. All the drugs that can cause SLE-like syndrome, the mnemonic is SHIP, S-H-I-P-P-E. Sulfa drugs: hydralazine, isoniazid, procainamide, phenytoin, and etanercept. So procainamide, that's a class 1A, causes SLE-like syndrome. INH, TB drug. Phenytoin, gingival hyperplasia and anti-epileptic. Hydralazine dilates the venous vasculature. Etanercept and sulfa drugs, they all cause SLE-like syndrome. Another rheumatoid arthritis drug, gold salts. Gold salts inhibit macrophage activity and decrease lysosomal enzyme activity. So gold salts inhibit macrophages and lysosomal enzymes. What's a prostaglandin that treats erectile dysfunction and maintains PDA? Alprostadil. Alprostadil is a vasodilator and relaxes smooth muscles. Alprostadil. Alprostadil and misoprostol are both PGE1. Alprostadil, misoprostol, PGE1. What are the side effects of alprostadil? Penile pain, priapism, hypotension, bradycardia. What about misoprostol? The other PGE1 is diarrhea, and then it's abortifacient. What is misoprostol used to treat? It prevents gastric ulcers with NSAIDs, and when given with methotrexate, it's an abortifacient. Misoprostol. First dinoprostone. Dinoprostone is the PGE2. Dinoprostone increases uterine contractions. Dinoprostone just causes GI upset, and it's also an abortifacient. Abortifacients are dinoprostone, carboprost, and misoprostol. Now for the PGF2A analogs are carboprost and latanoprost. Carboprost, as I said before, is an abortifacient. Latanoprost treats glaucoma. Latanoprost treats glaucoma. Latanoprost. It has no side effects. Side effects of carboprost are pulmonary hypertension, anaphylaxis. But carboprost, pulmonary hypertension, side effect. Now for the PGI analogs, there are three of them: iloprost, treprostinil, epoprostenol. So iloprost, treprostinil, and epoprostenol are PGI analogs. PGI inhibits platelet aggregation. So I will cause increased blood flow. You get no clotting with PGI. No clotting with PGI. You treat pulmonary arterial hypertension with PGI analogs: treprostinil, epoprostenol, and iloprost. PGI also vasodilates, so inhibits platelet aggregation and dilates. So you get lots of blood flow and increased blood vessel size with PGI. Also note that for carboprost, a side effect is pulmonary hypertension, but the PGI analogs, you're treating pulmonary arterial hypertension. Side effects of PGI, think flushing, headache, hypotension. Flushing, headache, hypotension, PGI. You also get GI upset, jaw pain, PGI, jaw pain. Also congestive heart failure, cardiac arrhythmias specific to iloprost. So, flushing, headache, hypotension, jaw pain, heart failure, cardiac arrhythmias. Now for interferons. Interferon A, produced by leukocytes. Interferon B, produced by fibroblasts. B, interferon B. Interferon gamma, CD4 T cells, CD4 cells, interferon gamma. How do you treat chronic granulomatous disease? Which interferon? Gamma. Gamma, chronic granulomatous disease. How do you treat hepatitis B and C? Alpha, interferon alpha. And it also treats certain types of cancer like Kaposi's, melanoma, hairy cell leukemia. That's interferon A, treats hepatitis B and C, Kaposi sarcoma, melanoma, hairy cell leukemia, hepatitis B and C, interferon A. How do you treat multiple sclerosis? Interferon B. Multiple sclerosis is interferon B. Remember that with all interferons, you get fatigue, bone marrow suppression, flu-like symptoms, and hepatotoxicity. So interferons can be hepatotoxic. What's an immunosuppressant drug that does the same thing as ribavirin? Mycophenolate mofetil. It inhibits the conversion of IMP to GMP by IMP dehydrogenase. It's mycophenolate and ribavirin inhibit IMP dehydrogenase. What does mycophenolate mofetil treat? Transplant patients immunosuppressant. Also treats psoriasis and SLE. So there's three things that mycophenolate mofetil treats. What are they? Transplant patients, psoriasis, SLE. It's mycophenolate mofetil. Because mycophenolate mofetil is an immunosuppressant, side effects are pancytopenia, GI upset and GI bleed, increased risk of lymphomas. So mycophenolate, increased risk of lymphomas, pancytopenia, GI upset, and GI bleed. Remember that the liver metabolizes mycophenolate into mycophenolic acid in the liver. And then it acts on B and T lymphocytes to inhibit inosine monophosphate dehydrogenase. So cellular proliferation of B and T cells is decreased. What kind of medication cause tinnitus, interstitial nephritis, hepatitis, GI bleeding? It's NSAIDs. It's both kidney and liver for NSAIDs, as well as hearing loss tinnitus for NSAIDs. Aspirin and ibuprofen can also displace what from what? They can displace thyroid hormones from thyroid hormone binding proteins. So in hyperthyroid patients, you avoid aspirin and ibuprofen because they displace thyroid hormones. Ibuprofen and aspirin can cause hemolysis in G6PD deficiency, just like isoniazid, sulfonamides, dapsone, primaquine, and nitrofurantoin. So aspirin and ibuprofen, hemolysis in G6PD. Prostaglandins normally vasodilate the afferent arteriole, so ibuprofen and NSAIDs block this. So there's renal ischemia. Interstitial nephritis is caused by NSAIDs, methicillin, furosemide. Interstitial nephritis, NSAIDs. Gastric ulcer, NSAIDs. NSAIDs can also cause aplastic anemia. Can't make new blood cells properly. Carbamazepine, methimazole, NSAIDs, benzene, chloramphenicol, propylthiouracil. Can't make new blood cells properly. C. Carbamazepine. N. NSAIDs. M. Methimazole. C. Chloramphenicol. P. Propylthiouracil. B. Benzene. Can't make new blood cells properly. C, M, N, B, C, P. For osteoarthritis and rheumatoid arthritis, NSAIDs are part of the treatment, along with glucocorticoids. Indomethacin also treats acute gout. So NSAIDs, gout. Acute gout is treated by NSAIDs, glucocorticoids, and colchicine. Chronic gout is treated with allopurinol and febuxostat. Pseudogout is also treated with NSAIDs. Pseudogout treatment is NSAIDs, glucosteroids, and colchicine. So it's the same as what you treat acute gout with. NSAIDs also treat SLE. Treatments for SLE: NSAIDs, glucosteroids, immunosuppressants, hydroxychloroquine. A triad of treatment with aspirin is nasal symptoms, bronchospasm, and facial flushing, as well as nasal polyposis. This is caused by overproduction of leukotrienes. Overproduction of leukotrienes occurs when aspirin blocks the cyclooxygenase pathway, causing arachidonic acid to be diverted into the lipooxygenase pathway and make leukotrienes. This goes hand in hand with asthma. NSAIDs like naproxen can cause fluid retention and worsening of hypertension. First-line treatment for acute gouty arthritis is NSAIDs. When the patient is on warfarin, aspirin increases the risk of bleeding. This is not only because aspirin displaces warfarin from its protein binding site, it's also because of antiplatelet effects and GI ulceration. As far as uric acid is concerned, what do you get when you have a low dose of NSAIDs? You have hyperuricemia. So high blood. Low doses of NSAIDs will decrease the secretion of uric acid, keeping it in the blood. Low doses keeps it in the blood. High doses of NSAIDs will kick the uric acid into the urine. High doses decrease resorption, so high doses kick the uric acid into the urine. Also, a high dose of NSAIDs increases respiration, respiratory alkalosis. High dose of NSAIDs will uncouple oxidative phosphorylation, and you'll breathe fast. High dose of NSAIDs, respiratory alkalosis. Then the kidney will compensate by increasing bicarbonate secretion, so it'll be compensated respiratory alkalosis. Now, a toxic dose of NSAIDs, on the other hand, will inhibit the respiratory center, respiratory acidosis. And then severe uncoupling of oxidative phosphorylation with a toxic dose will cause metabolic acidosis, hypokalemia, hyperthermia. High temperature, low potassium, metabolic acidosis after the uncoupling, and then when the respiratory center is inhibited, respiratory acidosis. So high dose, think alkalosis. Toxic dose, think acidosis. All starting respiratory. And then the toxic will proceed eventually to metabolic acidosis, I think. Don't quote me on that. Also, the tinnitus side effect can cause tinnitus, vertigo, and hearing loss. Now on to acetaminophen. Overdose is treated with acetylcysteine, which uses sulfhydryl groups to bind and inactivate the toxic metabolite of acetaminophen. Sulfhydryl groups. Back to NSAIDs. So if you have a child with a viral infection and aspirin, and then they probably have Ray's syndrome, which causes encephalopathy. So viral infections, this is associated with Ray's syndrome. Sulfa drugs, all the facts. Fact, 3 S's. Sulfa drugs. Okay. Probenecid, furosemide, acetazolamide, celecoxib, thiazides, sulfonamide antibiotics, sulfasalazine, sulfonylureas. So, and it's popular facts. Probenecid is popular. Then furosemide, acetazolamide. So that's 2 diuretics, acetazolamide and furosemide. The tau one and the PT one. Sulfa drugs. And then also thiazides. or yeah, the loop one and then the tau one. So basically all the diuretics are sulfa drugs, basically, or most of them. Sulfa drug allergies are Stevenson-Johnson syndrome, urinary tract infection, hemolytic anemia, low platelets thrombocytopenia, agranulocytosis, which would go with anemia and low platelets, and then also urticaria, hives. Remember that celecoxib, which is a sulfa drug, increases risk of thrombosis. Celecoxib increased risk of thrombosis. And it also causes interstitial nephritis and GI upset. So you might see a stroke or a heart attack with celecoxib, possibly. And a similar drug which was withdrawn is rofecoxib. That was definitely had increased heart attacks and stroke. What type of asthma do you treat with zafirlukast or montelukast? Chronic asthma. Zafirlukast is preventative treatment of asthma. Zafirlukast and montelukast inhibit what LTC, LTD, and LTE would do, which is increase bronchial tone, so they inhibit this. So if aspirin induces asthma, you'd treat that with zafirlukast or montelukast. Zafirlukast and montelukast also apparently inhibit cytochrome P450, so it's the acute gentleman sipped iced tea quickly and chewed soft cinnamon rolls, zafirlukast and montelukast. Cyclosporin side effects. Think all the bad ones. So hyper, and nephrotoxic and hepatotoxic. So you'll get also an increased incidence of lymphomas with cyclosporine. Cyclosporin increases risk of lymphomas. So hyperkalemia, hypertension, hyperglycemia. Potassium up, glucose up, hypertension up for cyclosporin. And then it's also nephrotoxic and hepatotoxic. And then also it causes hirsutism and gingival hyperplasia. Cyclosporin causes hair growth, like hirsutism. Cyclosporin causes your gums to be hyperplasia, gingival hyperplasia. And then tacrolimus, on the other hand, is similar, but there's no hirsutism or gingival hyperplasia. With tacrolimus, there's increased risk of diabetes and neurotoxicity, especially. So tacrolimus, think risk of diabetes and neurotoxicity. And they were both immunosuppressants for transplant patients. So think rheumatoid arthritis, psoriasis, IBD, and transplant patients. Cyclosporine, increased risk of lymphoma, also. Rituximab. Rituximab doesn't just treat NHL, it also treats polyangiitis, microscopic polyangiitis, and Wegener's granulomatosis. So I think you're putting on a tux for Wegener. And polyangiitis and microscopic polyangiitis are what rituximab treats. And it also treats chronic lymphocytic leukemia, so CLL, and NHL, obviously. Side effects, the biggest one for rituximab is renal failure. Rituximab renal, acute renal failure, rituximab renal. Rituximab can also cause neutropenia and pulmonary toxicity. The tumor lysis syndrome causes acute renal failure in rituximab, increased susceptibility to infection, pulmonary toxicity, and neutropenia for rituximab. More side effects include hypertension, infection, rhinitis, nausea, fever. Rituximab, acute renal failure, pulmonary toxicity, neutropenia, hypertension, infection, rhinitis, nausea, fever. You might also see irregular heart rhythms or and pancytopenia, which would go along with the neutropenia caused by rituximab. When you're giving rituximab to treat rheumatoid arthritis, you use it with methotrexate. Also, rituximab treats ITP. So is that immune thrombocytic purpura? I don't know. Now, what is the monoclonal antibody against HER2? Think of the trash tumor man checking out her. So it's trastuzumab, trash tumor man. Trastuzumab is a monoclonal antibody against HER2. Side effects are cardiotoxicity. That's the big one. But trastuzumab can also cause neutropenia, just like rituximab can also cause neutropenia. So can trastuzumab. But that's a minor one. The big one is cardiac toxicity. Trastuzumab treats breast cancer and gastric cancer with the HER2/NEU receptor. Trastuzumab. Remember that HER2 is a tyrosine kinase. HER2 is a tyrosine kinase. What are some other tyrosine kinases? BCR-ABL, RET. Those are other tyrosine kinases. But remember, RET is MEN2A and 2B, and BCR-ABL is CML and ALL. In the chemotox man, the cardiotoxicity drugs are trastuzumab and doxorubicin. It's a D-shaped heart with a T in it, so it's doxorubicin and trastuzumab. And the HER2 new gene is also called ERB-B2. ERB is HER. Let's say you have a cancer patient with fluid retention. What are they being treated with? Imatinib, fluid retention. It also causes nausea, rash, and heart failure. Imatinib, nausea, rash, heart failure, fluid retention, edema. Imatinib, edema. Imatinib treats GI stromal tumors and CML, so think GIST and camel with imatinib. It's the strawman, the GI strawman on the imatinib mat, and also the camel, and they're duking it out. Imatinib is also Gleevec, inhibits BCR-ABL tyrosine kinase. And for treating the GI stromal tumors, it inhibits c-KIT tyrosine kinase. So c-KIT and BCR-ABL. Imatinib. Imatinib specifically blocks the ABL portion. Imatinib blocks the ABL portion, blocks ABL of CML. CML is treated with not just imatinib, but also hydroxyurea, bone marrow transplantation, and splenectomy, but also hydroxyurea and imatinib treat CML. This is because with CML you'll see splenomegaly and blastic crisis, and low leukocyte alkaline phosphatase, obviously. So, ribonucleotide reductase inhibitor. Obviously hydroxyurea. Biggest side effect of hydroxyurea is bone marrow suppression and GI upset. And it's used to treat CML, polycythemia vera, melanoma, and sickle cell disease. So hydroxyurea treats those four things. CML, sickle cell disease, melanoma, and polycythemia vera. CML, hydroxyurea, sickle cell disease, CML, melanoma, hydroxyurea, polycythemia, hydroxyurea, sickle cell disease, CML, hydroxyurea, melanoma, hydroxyurea. What phase of the cycle does hydroxyurea act in? The S phase. The S phase, hydroxyurea, the S phase. Hydroxyurea inhibits ribonucleotide reductase in the S phase. Bone marrow suppression. Hydroxyurea. Hydroxyurea increases hemoglobin F. So what medications act in the S phase? That's hydroxyurea and topoisomerase 1 and 2 inhibitors. Topoisomerase 1 and 2 act in the S phase. So lastly, what treats hairy cell leukemia? Well, cladribine, which inhibits adenosine deaminase, and pentostatin, which inhibits adenosine deaminase. So cladribine, and pentostatin both inhibit adenosine deaminase, treating hairy cell leukemia. So adenosine deaminase would degrade purine nucleotides. This is inhibited by pentostatin and cladribine. Also, pentostatin is irreversible. Inhibit microtubule formation is vincristine and vinblastine. Formation, vincristine, vinblastine. But disassembly is paclitaxel. Paclitaxel is microtubule disassembly. So paclitaxel binds tubulin, and this stabilizes and polymerizes the mitotic spindle in metaphase. Anaphase cannot occur. Blocks it in metaphase. Paclitaxel metaphase. Side effects of paclitaxel are bone marrow suppression, hypersensitivity reaction, and neurotoxicity. So paclitaxel, think bone and brain, marrow suppression, neurotoxicity. Paclitaxel is also coats coronary artery stents, prevents restenosis. Paclitaxel treats 3, 4, 5 cancers. The big ones that paclitaxel treats are, think female cancers. Paclitaxel, think ovarian and breast cancer. Also advanced Kaposi sarcoma and head and neck cancers. Paclitaxel, ovarian, breast cancer, Kaposi, head and neck cancer. Another side effect in addition to another side effect is alopecia, and then the other side effects are myelosuppression. So myelosuppression, alopecia, neurotoxicity, paclitaxel. So both vincristine and vinblastine and paclitaxel do M-phase arrest, I guess. But with vincristine and vinblastine, they treat solid tumors, leukemias, and lymphomas. Paclitaxel treats ovarian and breast carcinomas. Paclitaxel binds beta-tubulin. So the microtubules will be a disorganized array for paclitaxel. Okay, new drug. So let's say you needed to treat solid tumors like testicular, prostate, glioblastoma multiforme in the brain, small cell lung carcinoma, as well as lymphoma or leukemia. You would use etoposide. Similar drug is tenofovir. Etoposide, it's the etoposide for two reasons. One, because it inhibits topoisomerase 2, which leads to DNA strand breakage, so it inhibits that. And then the other one is that it acts in the S to G2 phase. So S to G2 is where the topoisomerase inhibitor etoposide acts. Side effects are bone marrow suppression, baldness, alopecia, GI upset. So etoposide makes you bald and bone marrow suppressed in etoposide. Remember that topoisomerase is also known as gyrase in prokaryotes, but that's a side note. So both etoposide and fluoroquinolones inhibit topoisomerase 2. So vincristine and vinblastine, both of them treat lymphomas. Both vincristine and vinblastine, what do they treat? Lymphomas. Vinblastine in particular treats ball cancer, testicular cancer, as well as breast cancer, non-small lung cancer, and also lymphomas. So vinblastine, ball cancer. Vincristine treats ALL. So ALL, which is the... So remember that Picmonic where Luke is dueling Darth Vader, and that's the ALL mnemonic? You could say that the girl that he's saving, who's having her quinceañera, is named Cristine, for vincristine. That's what is treated with ALL, vincristine, as well as Wilms tumor and Ewing sarcoma. So vincristine treats lymphomas, ALL, Wilms tumor, and Ewing sarcoma. And vincristine and vinblastine both act during the MM phase. So vincristine and vinblastine. And they prevent mitotic tubule formation during the M phase. So vincristine is obviously, the side effects are peripheral neuropathy as well as baldness, GI upset, and myelosuppression is rare but usually mild. So don't worry about that. Just think peripheral neuropathy and maybe baldness. And vinblastine is bone marrow suppression and baldness as well. If you have a patient with finger numbness and tingling, it might be caused by vincristine. So new drug, which phase of the cell cycle does cytarabine act in? Well, it's a nucleoside analog, so it's during the S phase, and it's a pyrimidine analog. Acts in the S phase of the cell cycle. And it treats AML and lymphomas. So AML, think American Monkey League, or American Monkey Legion, with the signpost that has 15 and 17 between it, and then think that there's site Arabs coming to attack the monkeys in the AML. So cytarabine treats AML as well as lymphomas. Think AML especially for cytarabine. Side effects of cytarabine are, you guessed it, bone marrow suppression with resulting pancytopenia. So especially with cytarabine, you get pancytopenia. You also get baldness, GI upset, and ataxia. So remember, cytarabine, ataxia, and bone marrow suppression with cytopenia. What's the number one thing you think of when you see 5-fluorouracil? It treats adenocarcinomas. 5-fluorouracil treats adenocarcinomas that can be gastric, pancreatic, colon especially, breast, and ovarian. And it also treats, what's the other thing? Basal cell carcinoma. So 5-fluorouracil, think adenocarcinomas, basal cell carcinomas. And then side effects for 5-FU are also bone marrow suppression, obviously, but also the other ones are photosensitivity, anorexia, and oral ulcerations. And so if you try to use leucovorin to rescue the myelosuppression, it does not work with 5-FU. That's only methotrexate. Leucovorin does not work with 5-FU. But for overdose, if you overdose on 5-FU, what do you treat it with? It's in the name. Uridine. 5-FU, uridine. 5-FU, uridine. For treating basal cell carcinoma, you apply 5-FU topically. So with 5-FU, you're going to have low DTMP, 5-FU down temp. So 5-FU to the down temp. And decreased DNA and protein synthesis. Also remember that 5-FU covalently complexes folic acid. 5-FU complexes folic acid. This is after it's activated, of course. And what cell cycle phase does 5-FU act during? The S phase. It's like turn that 5 in the 5-FU to an S. That's S phase. Remember how vincristine treats ALL? Well, there's another one that treats ALL, and it's 6-mercaptopurine, 6-MP. So think in that mnemonic where Darth Vader is being attacked by Luke, and then the girl is having her quinceañera. Her name is Christine. There's a 6-MP, so like a military police, also attacking Darth Vader. So 6-MP also treats ALL, as well as non-Hodgkin lymphoma. ALL also treats non-Hodgkin lymphoma. And it also treats IBD and psoriasis. So that's like 4 things that 6MP treats: psoriasis, IBD, ALL, and NHL. What metabolizes 6MP? Xanthine oxidase, an enzyme involved in purine degradation. So when allopurinol and 6MP are given simultaneously, you get increased 6MP because it can't be broken down into thio-IMP by HGPRT. Wait. Okay. So 6MP is converted into thio-IMP by HGPRT, which is a salvage pathway. And then thio-IMP is a purine. So 6MP, think purine. And it is involved in the feedback inhibition. Okay. Thio-IMP is also converted to thio-GTP. So when I said 6MP is a purine, it's specifically a guanosine. And so it's both broken down by HGPRT and xanthine oxidase. But think HGPRT to activate it and xanthine oxidase to break it down. Another analog of 6MP is azathioprine. So in the ALL mnemonic, the 6MP guy can also be an azathioprine guy. So azathioprine is used as an immunosuppressant, just like 6MP can be, for SLE, inflammatory bowel disease, rheumatoid arthritis, ITP, which is immune thrombocytic purpura, and multiple sclerosis. So there's another MS drug besides the, I think it was the interferon gamma. Is it gamma or is it B? I'll have to check. It's interferon B, which treats MS, which is B is produced by fibroblasts, A is produced by leukocytes, gamma is produced by CD4 T cells. So the one that treats MS is the one that's produced by fibroblasts, interferon B. And what also treats multiple sclerosis is azathioprine. And azathioprine also treats what? SLE, IBD, rheumatoid arthritis, ITP, and multiple sclerosis. And then also think IBD and psoriasis. And it turns out that azathioprine can also cause gallstones. Yeah, gallstones, azathioprine. Other things that cause gallstones are sulfasalazine, furosemide, valproic acid, mumps, Coxsackie, mycoplasma. Also hypertriglyceridemia, hypercalcemia, surgery, blah, blah, blah. But remember, the drugs that cause gallstones are S, sulfasalazine, V, valproic acid, F, furosemide, A, azathioprine. Oh, never mind, that's actually acute pancreatitis, but you would see gallstones, so acute pancreatitis is all the things I listed. Drug causes of megaloblastic anemia, 3 of them. Think PMS, because megaloblastic, PMS is a blast, so think PMS for megaloblastic anemia. P, phenytoin, M, methotrexate, S, sulfa drugs. So phenytoin and methotrexate, megaloblastic anemia. Now things that cause pulmonary fibrosis. Breathing badly from medications. Breathing air badly, BABM. Breathing air badly from medications. Breathing, bleomycin. Air, amiodarone. B, busulfan. M, methotrexate. Bleomycin, amiodarone, busulfan, methotrexate cause pulmonary fibrosis. So what are the 3 things that inhibit dihydrofolate reductase? Well, it's trimethoprim, methotrexate, and pyrimethamine. what the protozoa drug. So methotrexate is a folic acid analog. Also causes folic acid deficiency. Inhibits dihydrofolate reductase. Reduces TMP. Reduces DNA and protein synthesis. Now, methotrexate is a chemotherapeutic, an immunosuppressant, and an abortifacient. So for chemotherapeutic, what does methotrexate treat? A variety, such as ALL, lymphomas, breast cancer, head and neck cancer, osteosarcoma, choriocarcinoma. The things that I didn't know really are osteosarcoma and choriocarcinoma. So then also for the ALL, so Luke is being treated by the 6MP guy and the azathioprine guy in the ALL demonic. And then so also there's a T-Rex in there. So 3 things that treat ALL: methotrexate, azathioprine, and 6MP. And I guess there would be one more. Oh yeah, it's vincristine because the quinceañera woman is named Kristen. So yeah. Then methotrexate also treats, as an immunosuppressant, treats rheumatoid arthritis, Crohn's disease, scleroderma, and psoriasis. Then it's an abortifacient when administered with misoprostol, I think. Side effects of methotrexate. The obvious one is bone marrow suppression, but methotrexate is both hepato and nephrotoxic. So methotrexate, think that it's both liver and kidney toxic. And it's also a teratogen. So in the moth T-Rexate, think that there was a tarantula trying to also capture the moth before the T-Rex got to him. And then methotrexate causes pulmonary toxicity or fibrosis or whatever because it's breathing air badly drugs or whatever. Breathing air badly from medications, methotrexate. Just like bleomycin, amiodarone, and busulfan. Then methotrexate also causes mucositis, and that it also causes seizures and baldness. So methotrexate also seizures. Then leucovorin, which is folinic acid, rescues methotrexate B9 deficiency. And so that minimizes bone marrow suppression. As far as methotrexate in rheumatoid arthritis, methotrexate is the first line for a moderate to severe, quickly diagnosed rheumatoid arthritis. Other side effects of methotrexate in New World are stomatitis, which is an infection of the mouth and lips. So stomatitis, methotrexate. And then also liver function because, yeah, it's liver toxic and nephrotoxic. Methotrexate, S phase. Methotrexate acts in the S phase. So a patient has fever, painful mouth ulcers, and pancytopenia, and that is caused by methotrexate. What does methotrexate inhibit? MTX inhibits DHF. MTX inhibits DHF reductase. MTX inhibits DHF. MTX DHF. So methotrexate inhibits both the synthesis of purines and thymidine. Cisplatin. Cisplatin causes nephrotoxicity and autotoxicity. Also, cisplatin causes neurotoxicity and bone marrow suppression. What do you use to treat the nephrotoxicity if you're using cisplatin? Amifostine. Amifostine treats cisplatin-induced nephrotoxicity. Amifostine. Remember that cisplatin is an alkylating agent. Inhibits DNA and RNA synthesis by binding DNA strands and cross-linking between strands. Cisplatin, alkylating agent. So cisplatin obviously treats testicular cancer, but it also treats lung, bladder, ovarian cancer, and carcinomas. So think genitourinary tumors, testicular, ovaries, and bladder. And small cell lung cancer, stomach and esophageal, and lymphomas. For cisplatin. Small cell lung cancer, stomach, esophageal, and lymphoma. So, what are all the drugs that are both nephro and autotoxic? There are 4 of them. Cisplatin is one of them. Aminoglycosides is another one. Vancomycin and loop diuretics. So remember how I said that cisplatin alkylates? Well, so do nitrosarias. Nitrosarias such as carmustine, lomustine, semustine, and streptozocin. They are alkylating agents. They cross-link DNA and inhibit RNA and DNA synthesis. So nitrosarias are, one begins with a C, one begins with an L, one begins with an S, one begins with an S. So it's CLSS. Carmustine, lomustine, semustine, streptozocin are nitrosarias. They cause bone marrow suppression, nephrotoxicity, just like cisplatin, and pulmonary fibrosis. So carmustine, lomustine, semustine, and streptozocin all cause pulmonary fibrosis. So the drugs, so breathing air badly from medications, bleomycin, amiodarone, busulfan, methotrexate, and apparently also nitrosarias such as carmustine, lomustine, semustine, and streptozocin. So what are the 3 cancers that you would treat with nitrosarias? Think brain, and multiple myeloma, then lymphomas. So brain tumors, it's glioblastoma, multiple myeloma, lymphoma. GML. What do you treat with nitrosarias? Glioblastoma, multiple myeloma, lymphomas. What are the toxicities of nitrosarias? List 2 of them or 3 of them. Nephrotoxicity, nitrosarias, nephrotoxic, nitrosarias, nephrotoxic, pulmonary fibrosis, and bone marrow suppression. Side note, nitrosarias do cross the blood-brain barrier. That's why they're good at treating glioblastoma. Nitrosarias cross the blood-brain barrier. Remember that nitrosarias are not initially active. They need to be converted to active metabolites by hepatic cytochrome P452B. So nitrosarias need to be activated by the liver. Another side effect for nitrosarias, in addition to the nephrotoxicity, pulmonary fibrosis, and bone marrow suppression, they're also CNS toxic. So they go into the CNS and they are CNS toxic. You'll see convulsions, ataxia, dizziness for nitrosarias. Carmustine, lomustine, semustine, streptozocin. That's convulsions, dizziness, ataxia. Another alkylating agent that starts with the B. Busulfan. And we know that causes pulmonary fibrosis. But it also causes adrenal insufficiency with hyperpigmentation. So busulfan, you might see Addison's. Busulfan, Bueller, Addison. Bueller, busulfan, Addison. You'd also see seizures with busulfan and bone marrow suppression. So seizures, Bueller, Addison's, pulmonary fibrosis. Busulfan treats CML. So busulfan is on the camel. Busulfan. And before a bone marrow transplantation, you would ablate the patient's bone marrow with busulfan. Why? Because busulfan cross-links DNA as an alkylating agent, apparently. Busulfan treats CML. Busulfan is on the camel. So Bufan mimics Addison's disease. But the gold standard of treatment for CML is still Gleevec or imatinib. Now we're doing cyclophosphamide. Cyclophosphamide also cross-links DNA, and it is also metabolized to a hydroxylated compound by cytochrome P450 in the liver. So it's another one that needs to be activated before it can be active. I think the other one that needed to be activated by the liver is nitrosoureas. So it would be nitrosoureas and cyclophosphamide that are activated by the liver. So what does cyclophosphamide treat? Wow, a variety of things. It treats solid and hematologic malignancies, breast, ovarian, NHL, also rheumatoid arthritis, SLE, Wegener's granulomatosis for cyclophosphamide, and nephrotic syndrome. So cyclophosphamide, nephrotic syndrome. And also polyarteritis nodosa, you'd also give glucocorticoids for that. Microscopic polyangiitis, you'd also give glucocorticoids for that. And Wegener's granulomatosis. Remember, these are all treated by cyclophosphamide. Breast, ovarian, NHL, rheumatoid arthritis, SLE, cyclophosphamide, SLE. And it has some interesting side effects. You already know about the hemorrhagic cystitis that you treat with Mesna, but it also causes bone marrow suppression, GI upset, alopecia, and infertility. Cyclophosphamide makes you infertile, as well as two other things. Cyclophosphamide can cause SIADH, symptom of inappropriate ADH secretion, and transitional cell carcinoma. So think cyclophosphamide, SIADH, and transitional cell carcinoma causing cyclophosphamide. Transitional cell carcinoma, cyclophosphamide, SIADH, cyclophosphamide. So for this SIADH, remember that there are other drugs that can also cause it. There are two other ones. So there's 3 drugs in total that cause SIADH. CCSS, can't concentrate serum sodium, carbamazepine, cyclophosphamide, SSRIs. Now we're gonna remember what causes transitional cell carcinoma. One begins with an A, that's aniline dyes. One begins with a P, that's phenacetin. One begins with an S, that's smoking. Then cyclophosphamide. So the mnemonic is PSAC. P, phenacetin, and then SAC. You're peeing out of the sac of the transitional cell carcinoma, which is smoking, aniline dyes, and cyclophosphamide. And in transitional cell carcinoma, you'll see papillary growth lined by transitional epithelium with mild nuclear atypia and pleomorphism. Remember, cyclophosphamide needs bioactivation by the liver. Now, just quickly, 2 other medications that are alkylating agents, mechlorethamine and procarbazine. So let's do mechlorethamine first. Mechlorethamine, what does it treat? Hodgkin lymphoma. Now procarbazine, what does procarbazine treat? Hodgkin disease and some brain tumors, so Hodgkin lymphoma probably. Okay, but procarbazine, you gotta remember, it has the disulfiram-like reaction. Procarbazine, disulfiram-like reaction. As well as a metabolite of procarbazine inhibits what? And patients taking this drug should not ingest tyramine. So wine, smoked meat, cheese. What does it inhibit? Monoamine oxidase. Procarbazine metabolite inhibits monoamine oxidase. So you should not consume tyramine with procarbazine. Now, you know bleomycin pretty well. So bleomycin, remember that it triggers the formation of oxygen-free radicals, and then it's used for testicular tumors, Hodgkin lymphomas, and squamous cell carcinoma of the head, neck, skin, penis, cervix. And bleomycin also causes pulmonary fibrosis, skin changes, and the mucositis. So myelosuppression is rare with bleomycin. So if you're worried about myelosuppression, use what? It begins with a B. If you're worried about myelosuppression, what do you use? Bleomycin. And bleomycin, what phase of the cell cycle does it work in? It is cell cycle specific, so you would accumulate cells in the G2 phase of the cell cycle for bleomycin. Bleomycin, think all the cells are becoming G2. Bleomycin side effects, you also see blistering and stomatitis, which is basically like inflammation of the mouth, I guess, or whatever. So blistering and stomatitis as well. And when you get pulmonary fibrosis, what does that lead to? Pulmonary what? What does pulmonary fibrosis lead to? Pulmonary hypertension. The skin changes associated with bleomycin might be described as flagellate skin discoloration. So, dactinomycin, what two base pairs does it intercalate between? Cytosine and guanine. So CG, dactinomycin is between the CG, so it's cytosine, then dactinomycin, then guanine. C, dactinomycin, G. So dactinomycin will inhibit DNA-dependent RNA polymerase. So RNA synthesis is impaired with dactinomycin because it's intercalating between the base pairs, so RNA polymerase can't copy. So DNA replication is also somewhat impaired. What do you use dactinomycin for? Two things mainly, but also in conjunction with a methotrexate for another thing. Dactinomycin, Wilms tumor, and Ewing sarcoma, and also with methotrexate to treat gestational choriocarcinoma. So, Wilms tumor, Ewing sarcoma, gestational choriosarcoma. What medication treats these? Dactinomycin. So, side effects of dactinomycin. One thing that's similar to bleomycin but described differently is skin abnormalities. So it'll be it's in patients that are in sites that have previously received radiation, so radiation recall, dactinomycin, skin abnormalities, as well as bone marrow suppression, GI upset, and increased susceptibility to infections. And then its similar drug, plicamycin. When plicamycin, think that it treats different cancers. Plicamycin treats testicular and Paget's. Testicular cancer and Paget's disease of the bone is what plicamycin treats. Paget disease, testicular cancer. And another thing that dactinomycin treats, rhabdomyosarcoma. So it's used for childhood tumors. Children act out. Dactinomycin. Wilms tumor, Ewing sarcoma, rhabdomyosarcoma, and gestational choriocarcinoma. The last drug of the section, doxorubicin, which is also daunorubicin and idarubicin. This one has three mechanisms. So first of all, what it treats. Think just hematological malignancies, ALL, lymphoma, multiple myeloma, Kaposi sarcoma, solid tumors, breast, ovary, bladder, endometrium, stomach, and lung cancers. So it has three mechanisms. They are daunorubicin, doxorubicin blocks DNA and RNA synthesis by inserting between base pairs, and they also cause production of free radicals, which leads to membrane damage, and they disrupt fluid and ion transport across the cellular membrane. So think of it like this. They intercalate, they do free radicals, and they disrupt the membrane. Okay, so what are the side effects of doxorubicin? Obviously, dilated cardiomyopathy, and that'll look like left and right-sided CHF. Left and right-sided heart failure could be a doxorubicin toxicity. It also causes bone marrow suppression, alopecia, and then, yeah. So you treat doxorubicin toxicity with what? Dexrazoxane. Dexrazoxane decreases free radical formation and treats doxorubicin toxicity. Ursodiol treats primary biliary cirrhosis and gallstones. It can cause GI upset. Ursodiol. It decreases gallstones in three ways. Ursodiol inhibits HMGA-CoA reductase, kind of like a statin, I think. Or that's just like a statin. Ursodiol is just like a statin. It also decreases intestinal reabsorption of cholesterol, just like a bile acid resin. And it inhibits secretion of cholesterol into bile. Now for sulfasalazine. Sulfasalazine, remember that it's a sulfa drug, so it has all those side effects. Sulfasalazine, think oligospermia is a side effect. Infertility is therefore a side effect. Bone marrow suppression for sulfasalazine, skin rash for sulfasalazine, headache, and bone marrow suppression and GI upset. Bone marrow suppression for sulfasalazine. In the colon, bacteria metabolize sulfasalazine into sulfapyridine and 5-ASA. 5-ASA is the anti-inflammatory, blah, blah, blah. 5-ASA inhibits prostaglandin and leukotriene production by inhibiting COX. And 5-ASA also scavenges oxygen radicals, prevents further mucosal damage. That's why it's treatment for IBD, both Crohn's disease and ulcerative colitis, and rheumatoid arthritis and juvenile arthritis. Sulfasalazine, juvenile arthritis. Also, another side effect. So, when it's metabolized to sulfapyridine, which is an antibacterial, can impair folic acid absorption. So, sulfapyridine could cause a benign malabsorption. So, you should administer sulfasalazine with folic acid. So, I said it causes GI upset, skin rash, headache, bone marrow suppression, infertility. It also causes malaise, nausea. So when I said that sulfasalazine causes bone marrow suppression and oligospermia, those are caused by sulfapyridine. Sulfapyridine causes agranulocytosis and hypospermia. It's sulfapyridine. Treating diarrhea with opioids. 2 drugs. Loperamide and diphenoxylate. They bind to opioid receptors in the intestine, inhibits acetylcholine release, decrease gut peristalsis. Diphenoxylate and loperamide. Loperamide, diphenoxylate, opioids. Side effects are pain, no. Just diarrhea? Yeah. Okay, although they treat diarrhea. Yeah, they treat diarrhea. If you have toxicity, treat with naloxone or naltrexone. What's a drug that absorbs potential intestinal toxins and reduces water loss in the colon? Kaolin pectin absorbs intestinal toxin, but it's not very effective. Another drug that binds intestinal toxin is bismuth subsalicate. It binds toxins produced by E. coli to inhibit intestinal motility by inhibiting prostaglandin synthesis and stimulating fluid absorption. So with bismuth, remember, the gut slows down and starts absorbing. With bismuth, which also binds intestinal toxins. Lower prostaglandin synthesis. Oh, and going back to diphenoxylate and loperamide, if you have ulcerative colitis, you don't use them. Why? Because, well, you probably know why. Antidiarrheals that are antimuscarinics. Dicyclomine, glycopyrrolate, L-hyoscyamine. That is dicyclomine, glycopyrrolate, L-hyoscyamine. They are antimuscarinics. If you have GERD, or gastroesophageal reflux, you don't use antimuscarinics. So you would not use dicyclomine, glycopyrrolate, hyoscyamine. What are some bulking osmotic laxatives? Lactulose, sorbitol, polyethylene glycol, magnesium salts such as magnesium hydroxide and magnesium citrate. These are bulking laxatives. What about irritants or stimulants? They are castor oil, senna, bisacodyl, lubiprostone. Lubiprostone activates a chloride channel. Lubiprostone activates a chloride channel. Lubiprostone activates a chloride channel. What activates a chloride channel? Lubiprostone. It's a stimulant, just like castor oil, senna, bisacodyl, lubiprostone. Now, what are two stool softeners? Docosate and mineral oil. So, mineral oil is a stool softener. Mineral soft mineral. Docosate is also a soft mineral. Stool softener. Keep in mind that the bulking osmotic laxative lactulose has a bad side effect. Lactulose can cause hepatic encephalopathy. So lactulose think that it breaks down into amines and causes hepatic encephalopathy. Bacteria in the intestine degrades lactulose into lactic acid and acetic acid. So they promote nitrogen excretion. And hence improves... No, it's not a side effect. Lactulose does not cause hepatic encephalopathy. It treats hepatic encephalopathy. Lactulose treats hepatic encephalopathy. What is bisacodyl? It's a stimulant. So what's the side effect of bisacodyl? Or two of them? Causes dehydration and low potassium. Down K, bisacodyl. Bisacodyl, down K. Low potassium and dehydration is what it causes side effects. Bisacodyl. Low K and dehydration. Now for metoclopramide. You know that's an antagonist at dopamine receptors, an agonist at serotonin receptors. So it treats GERD, nausea, vomiting, diabetic gastroparesis. It's an antiemetic. Side effects: it has extrapyramidal symptoms, diarrhea, hypotension, tardive dyskinesia, edema. Metoclopramide causes edema. It also increases prolactin because there's no dopamine to inhibit the prolactin. Remember that metoclopramide is basically similar to prochlorperazine. Prochlorperazine, metoclopramide. There is one difference, one addition that prochlorperazine does. Prochlorperazine. It also is an antagonist at anticholinergic receptors and alpha-1 adrenergic receptors. So it causes hypertension and blah blah blah. Just think of prochlorperazine as a dopamine antagonist. Nausea, it causes nausea. No, it treats nausea and treats migraines. Prochlorperazine treats migraines. And it's teratogenic. Prochlorperazine, two main things. Treats migraines, and it's teratogenic. So just as prochlorperazine antagonizes dopamine, promethazine antagonizes H1 receptors. Prometh H1. And also remember promethazine, because it's an anticholinergic, you'll get blurry vision, dry mouth as a side effects. So it decreases GI tract motility. Promethazine slows down the gut and makes you have blurry vision and dry mouth. Moving on, remember, omeprazole and proton pump inhibitors are irreversible. They bind, of course, HK, ATPase, blah, blah, blah. Suppresses gastric acid secretion. Causes headache and rash, but the big one for PPIs, proton pump inhibitors, omeprazole, is increased risk of hip fractures in elderly. So PPIs, increased risk of hip fractures in elderly. And you get increased risk of C. difficile infection as well. And you get decreased magnesium with long-term use. So, 3 major side effects: C. difficile, hip fractures, and decreased magnesium. HK-ATPase is considered primary active transport. Things that are primary active transport are NAK-ATPase, HK-ATPase, and calcium ATPase. Omeprazole causes hip fractures by decreasing calcium absorption. Also, don't be surprised if with omeprazole you see a respiratory infection, like a pneumonia with omeprazole. Now for H2 blockers: cimetidine, ranitidine, famotidine, nizatidine. So remember that they reversibly block histamine H2 receptors. What does that cause? Decrease acid secretion by the parietal cells. Now the side effects, there's some big ones. The biggest one that H2 receptor blockers like cimetidine cause are gynecomastia and headache. Why does it cause a headache? Because it's an H2 blocker, so it crosses the blood-brain barrier, causing confusion, dizziness, and headaches. And it crosses the placenta. Cimetidine crosses the placenta. And both cimetidine and ranitidine decrease creatine excretion. So you're going to have more creatine in your blood if you have H2 blockers like cimetidine. But the other H2 blockers are free from this. It's only cimetidine and ranitidine that decrease creatine secretion, so increase creatine in the blood. So cimetidine causes gynecomastia. It also causes impotence and decreased libido. So cimetidine, think anti-androgenic effects. And another little thing, cimetidine can also decrease platelets. So cimetidine, decrease platelets, increase creatine. Cimetidine. Now moving on to antacids: aluminum hydroxide, magnesium hydroxide, calcium carbonate, sodium bicarbonate. Calcium carbonate, sodium bicarbonate, aluminum hydroxide, magnesium hydroxide. So they reduce acidity. This decreases protein breakdown and protects the mucosal barrier by stimulating prostaglandin synthesis possibly. So you heal duodenal ulcers and treat gastroesophageal reflux disease with antacids. They treat two things: duodenal ulcers and GERD, antacids. Sucralfate is also the thing that treats duodenal ulcers. So now for the side effects. When you see aluminum or aluminum, I guess, or calcium. Aluminum hydroxide causes constipation. Magnesium hydroxide causes diarrhea, so they're kind of opposites. Aluminum, constipation. Aluminum slows. Magnesium, diarrhea. Calcium carbonate causes hypercalcemia and milk alkali syndrome. Sodium bicarbonate causes flatulence and metabolic alkalosis because you're consuming all that bicarbonate. Your bicarbonate's going up, and it also causes flatulence. Sodium bicarbonate causes flatulence. Also harping on aluminum, so it causes constipation, also causes low phosphate. Aluminum causes low phosphate and proximal muscle weakness and osteodystrophy and seizures. So aluminum amount of feces, constipation, low phosphate, proximal muscle weakness, osteodystrophy, seizures for aluminum. And for the calcium carbonate, the milk alkali syndrome is decreased effectiveness of tetracycline because calcium carbonate chelates tetracyclines. And you can also get rebound acid with calcium carbonate as well as hypercalcemia. And for magnesium hydroxide, so it causes diarrhea, also causes Hyporeflexia. Hyporeflexia. Just like muscle weakness is aluminum, so hyporeflexia is magnesium. Magnesium hydroxide, diarrhea, hyporeflexia, hypotension, and cardiac arrest. Magnesium hydroxide, hypotension, cardiac arrest, diarrhea, and hyporeflexia. Now for oxytocin. Oxytocin and vasopressin are transported by neurophycins, which are derived from neuroectoderm. Alcohol and stress inhibit oxytocin. And side effects of oxytocin are cardiac arrhythmias, uterine spasm, GI upset. So think cardiac arrhythmias from oxytocin. Now for vasopressin, what do V1 receptors do? Vasoconstriction. What do V2 receptors do? They act in the kidney. What do V2-like receptors do? They increase factor VIII activity. So you use vasopressin to treat central diabetes insipidus, as well as septic shock and cardiac arrest. And then you also use desmopressin to treat hemophilia A and von Willebrand disease. Remember that desmopressin only acts on V2 receptors and V2-like receptors. So desmopressin, only V2 receptors. So the side effects of vasopressin would be hyponatremia, hypersensitivity, vasoconstriction, but remember desmopressin does not activate V1 receptors, so you don't get vasoconstriction with desmopressin. And then you also get headache as a side effect of vasopressin. And you treat the side effect of vasopressin and desmopressin by restricting water intake. Vasopressin will also cause hyponatremia. Remember that you swell up with water if you take vasopressin or desmopressin. What increases von Willebrand factor? Desmopressin. Desmopressin causes factor VIII to release von Willebrand factor. Remember that lithium antagonizes vasopressin. Now for octreotide, how do you treat sulfonylurea toxicity? There are two therapies. One is dextrose, the other is octreotide. Sulfonylurea toxicity. How do you treat acromegaly? You use octreotide or bromocriptine. So acromegaly as well. Then also glucagonomas, insulinomas, and carcinoid syndrome. Side effects of octreotide: nausea, cramps, and gallstones, and arrhythmias. So gallstones and arrhythmias, octreotide. This is probably because there is a decreased release of gastrin, so that would probably slow down motility and cause gallstones. Another thing that treats acromegaly is pegvisomant, which is a growth hormone receptor antagonist. So, treating acromegaly, octreotide, and pegvisomant. If you have esophageal varices, you can also treat that with octreotide. The gallstones that octreotide can produce also might be described as steatorrhea. So when you have a cirrhosis patient who has portal hypertension and esophageal varices, you can treat that with octreotide. Now for oral contraceptives, the estrogen in oral contraceptives will inhibit FSH release, but at the same time they don't stimulate LH release, so there will be decreased FSH and LH, so no ovulation. Oral contraceptives treat the hirsutism side effect of, or cause of PCOS, polycystic ovarian syndrome. They also treat dysfunctional uterine bleeding, endometriosis, and dysmenorrhea. Combined oral contraceptives decrease the risk of ovarian and endometrial cancer. And progestin-only pills don't increase risk of thromboembolism. That's only the combined pills. Emergency contraception pills contain high doses of progestins. And the time limit for that is 72 hours after intercourse. Then mifepristone is an antagonist at the progesterone receptor. And it acts as an abortifacient. Mifepristone acts as an abortifacient by breaking down the endometrial lining and cervical dilation. So when you're treating PCOS, you use oral contraceptives and clomiphene and leuprolide. Clomiphene is a partial agonist at estrogen receptors in the pituitary gland. It decreases estrogen release. So it causes an increase in LH and FSH. Clomiphene is basically the opposite of oral contraceptives. Contraceptives would decrease FSH and LH. Clomiphene increases LH and FSH. The surge of LH and FSH stimulates ovulation for clomiphene, so it treats infertility. Clomiphene can cause hot flashes and abdominal discomfort, as well as multiple pregnancies. And clomiphene can cause visual disturbances. Now for leuprolide. How do you treat prostate cancer besides flutamide? You can also use leuprolide. Leuprolide also treats leiomyomas. Leiomyoma. And leuprolide also treats endometriosis. So leuprolide treats prostate cancer, leiomyomas, and endometriosis. And it also treats infertility when you administer it in a pulsatile fashion. GnRH agonists are nafarelin and gosarelin. So relin, think GnRH agonist. Nafarelin and gosarelin. Leuprolide can also cause hot flashes, just like clomiphene. And if given in a constant fashion, it can cause impotence. Leuprolide can cause impotence. Now for tamoxifen. Remember that tamoxifen acts as if that there is high levels of estrogen. So this increases venous thromboembolism risk. Tamoxifen increases DVT risk. Tamoxifen also causes fluid retention and vaginal bleeding, as well as hot flashes. So think thromboembolism and fluid retention for tamoxifen. Raloxifene also still has the increased risk of DVTs. With tamoxifen, you might see endometrial hyperplasia, which of course leads to endometrial cancer. So just like tamoxifen and raloxifene treat estrogen receptor positive breast cancer, there's another class of medications that treat estrogen receptor positive breast cancer. Anastrozole, exemestane. Anastrozole and exemestane. They inhibit aromatase, decrease estradiol levels, but unlike how tamoxifen and raloxifene treat osteoporosis, anastrozole and exemestane can cause osteoporosis. Other side effects of anastrozole and exemestane: hyperlipidemia, increased cardiovascular events with coronary artery disease, and hot flashes. So think that anastrozole and exemestane, they cause osteoporosis, hyperlipidemia, and coronary artery disease might be a contraindication. Also hot flashes. And tamoxifen and anastrozole, you use them in postmenopausal women specifically. Finasteride. So, 5-alpha reductase converts testosterone to dihydrotestosterone, which is a high-potency form. Finasteride inhibits this. It treats BPH, prostatic cancer, and baldness. Finasteride decreases libido and causes erectile dysfunction. Finasteride decreases libido and erectile dysfunction. Now moving on to a more complicated one, danazol. Danazol has two mechanisms. The androgen mechanisms are, it acts in two places. It acts in the anterior pituitary and in the ovary. And it's an agonist at both androgen and progesterone receptors. So danazol, think androgen and progesterone receptors. It decreases LH and FSH. So danazol, just like oral contraceptives would decrease LH and FSH, so does danazol. So it decreases endometrial tissue and breast tissue growth. It's usually used to treat endometriosis. So when danazol agonizes androgen and progesterone receptors, it decreases LH and FSH. It treats endometriosis. Also, danazol increases C1 esterase inhibitor. So it treats hereditary angioedema as well. So when you use danazol to treat C1 esterase inhibitor, it will increase levels of C4. And also, danazol treats fibrocystic disease of the breast and menorrhagia. So, to quickly sum up what it treats hereditary angioedema, endometriosis, and fibrocystic disease of the breast, and menorrhagia. Okay, side effects of danazol. Causes masculinization, probably because when it agonizes the androgen receptor. Causes hirsutism and acne, probably the same thing. Causes weight gain. It causes edema and elevated hepatic enzymes. So danazol will elevate hepatic enzymes, as well as you'll get hairy, masculinized, you'll gain weight, you'll gain water weight through edema, and your liver will have elevated enzymes with danazol. Now for flutamide. Just as danazol was an agonist for androgen receptors as well as progesterone receptors, flutamide antagonizes androgen receptors. So flutamide will decrease the effect of testosterone on the prostate, treating prostate cancer. You have to remember that when you block the effect of testosterone, LH levels will go up. So you need to use leuprolide with flutamide. Side effects of flutamide are GI upset, gynecomastia, and abnormal liver function tests. So when you inhibit the androgen receptors, you get gynecomastia. This is kind of the opposite of danazol, which you would get hirsutism and acne. But just like danazol, you also get abnormal liver function tests with flutamide. Colchicine. Colchicine binds tubulin and induces microtubular depolymerization, decreasing leukotriene B and decreasing neutrophil migration, blah, blah, blah. Colchicine is for acute gout attack. And colchicine also treats pseudogout. Colchicine also treats Behçet disease. And colchicine also treats scleroderma. So think acute gouty attack, pseudogout, Behçet disease, and scleroderma for colchicine. Side effects of colchicine: myopathy, bone marrow suppression, and diarrhea. So there are 3 side effects for colchicine. What are they? One is muscle, one is bone, one is diarrhea. Myopathy, bone marrow suppression, diarrhea for colchicine. And let's see. When you treat with allopurinol, you also give colchicine or an NSAID simultaneously. Now for probenecid. So it acts in the proximal tubule. For probenecid, it's prevention of gout as well as treating hyperuricemia, which is caused by tumor lysis syndrome. And also when you're giving cidofovir, remember that cidofovir is nephrotoxic, so you give cidofovir with saline and probenecid. So gout, hyperuricemia, and when you're giving cidofovir for probenecid. Contraindications for probenecid are if the uric acid levels are really high, like in acute gout, or if the patient has kidney stones, you don't use probenecid in that case. Another thing that probenecid does, it inhibits the renal excretion of penicillin and NSAIDs. So if you want to keep penicillin and NSAIDs in the blood, then you can use probenecid. Now for allopurinol, remember that it inhibits xanthine oxidase, so you'll get a buildup of xanthine and low uric acid with allopurinol. And it's also used for chronic gout. Side effects of allopurinol are decreased metabolism of 6-MP and azathioprine. So decreased metabolism of 6-MP and azathioprine for allopurinol. What are the side effects of propylthiouracil? Well, it causes a maculopapular skin rash, a granulocytosis, you knew that, and it's also hepatotoxic. So PTU is maculopapular skin rash, hepatotoxicity, and then you treat hyperthyroidism and thyroid storm with propylthiouracil. Thyroid storm is treated with beta blockers, propylthiouracil, and glucocorticoids like prednisolone. So that's the 3 Ps. Beta blockers, PTU, prednisolone. And then methimazole is the teratogen. What are the side effects of niacin? Well, besides flushing, it's eczema, acanthosis nigricans, and hyperuricemia. Niacin may exacerbate gout. Niacin may exacerbate gout. Niacin causes eczema and acanthosis nigricans. Niacin inhibits what? Hormone-sensitive lipase. Also, side note, remember that estrogen increases T4 levels. So estrogen increases thyroxine binding globulin levels and T4 levels and total T3. But the main thing is increased total T4 pool. This is for estrogen. Estrogen increases total T4 pool. So methimazole. Not only does methimazole decrease peripheral conversion of T4 to T3, beta blockers also decrease peripheral conversion of T4 to T3. Beta blockers. More side effects for niacin. So niacin causes eczema, acanthosis, hyperuricemia. It also causes hyperglycemia. So niacin causes hyperglycemia as well. So hyperuricemia and hyperglycemia for niacin. So fibrates like gemfibrozil, it's the gentleman in the acute gentleman sipped iced or grapefruit juice. So gemfibrozil, what are the 2 mechanisms? First of all, it activates PPAR gamma, which induces HDL synthesis. PPAR gamma or alpha. No, sorry, it activates PPAR alpha. Fibrates do, and that increases HDL synthesis. The other mechanism for fibrates is that they upregulate LPL, lipoprotein lipase. So fibrates upregulate lipoprotein lipase. This breaks down triglycerides into VLDL and chylomicrons. what are the side effects that you think of when you see fibrates? Well, gallstones, cholesterol gallstones that is, hepatotoxicity, myositis, abnormal liver function tests, so fibrates are hepatotoxic, and GI upset. Oh, and when you give fibrates with bile acid resins, your risk of gallstones really increases even more. So all anti-hyperlipidemic medications are basically hepatotoxic, except for bile acid sequestrants, but when given with fibrates, bile acid sequestrants increase risk of gallstones. Once again, anti-hyperlipidemics, think hepatotoxicity. Oh, and just like how aspirin competes with warfarin binding sites for albumin, so do fibrates. Fibrates amplify the effects of warfarin. Fibrates increase the effects of warfarin. So like how fibrates will increase the effects of warfarin, cholestyramine and bile acid resins will decrease the absorption of warfarin, as well as decrease absorption of digoxin, tetracycline, and thiazide diuretics. So cholestyramine or bile acid resins, think impaired uptake of warfarin, digoxin, tetracycline, and thiazides. Bile acids are usually reabsorbed in the jejunum and ileum especially. So how does the body respond to impaired uptake of bile acid resins? It increases production of cholesterol and increases LDL receptors. So this is increased uptake of serum LDL into the liver, decreasing serum LDL, but increased LDL receptors, and lower levels of intracellular cholesterol because cholesterol is constantly being produced. Also, remember that bile acid resins decrease absorption of fat-soluble vitamins A, D, E, and K, and folic acid, and of course warfarin, digoxin, tetracycline, and thiazides. So in type 2 hyperlipidemia, where you lack LDL receptors, cholestyramine and bile acid resins won't be as effective. So type 2 hyperlipidemia, bile acids resins will not be as effective. Also remember that bile acid resins, you could get gallstones, especially with fibrates. Which medication decreases absorption of cholesterol? Ezetimibe. Absorption of the cholesterol happens in the small intestine, and it's inhibited by ezetimibe. So when you get impaired absorption of cholesterol, a side effect of ezetimibe will be steatorrhea, diarrhea. It also causes myalgia, just like fibrates and statins. Ezetimibe also causes arthralgia, and ezetimibe is hepatotoxic. Elevated liver function tests. Ezetimibe. Steatorrhea, diarrhea, myalgia, arthralgia, and elevated liver function tests. So now remember that bile acid resins do what? Increase LDL receptors. So do statins. Bile acid resins and statins both increase the concentration of LDL receptors on hepatocytes. So what do you get with statins? Decreased total cholesterol, decreased LDL levels. 3 side effects for statins. Myopathy, abnormal liver function tests of statins are hepatotoxic, and teratogens. Statins are teratogens. Statins are teratogens. What are teratogens? Statins. Just like bile acid resins aren't as effective as in type 2 hyperlipidemic patients who lack LDL receptors, same thing with statins. So bile acid resins and statins not as effective in type 2 hypercholesterolemia. So when statins cause myopathy or rhabdomyolysis, acute renal failure can follow that. So statins may be associated with acute renal failure. Why? Rhabdomyolysis. So when statins cause acute liver injury, what will that look like? It will look like myalgia, muscle weakness, dark urine, and elevated creatine kinase. Again, associate statins with elevated creatine kinase, dark urine, and myalgias. Once again, statins are teratogenic, not safe to use in pregnancy. Now moving on to anti-diabetic agents. Meglinotides, repaglinide, nataglinide. So glinides, meglinotides. Meglinotides bind the potassium channel. Different than sulfonylureas on the B cells, release insulin. So what are the side effects of meglinotides? Hypoglycemia and weight gain. Why? Because meglinotide increases insulin release. This causes hypoglycemia and weight gain. Also, with meglinotides, repaglinide and nataglinide, you'll get tachyphylaxis over time and decreased muscle mass. So when meglinotides bind the potassium receptor, they decrease potassium efflux, which causes increasing calcium influx. Calcium in, the potassium does not get out. Potassium does not get out, so calcium goes in. Now for the DPP-4 inhibitors. They're the gliptins, so meglinotides are the glinides. DPP-4 inhibitors are the gliptins. DPP-4, gliptin. Sitagliptin, vildagliptin, saxagliptin, linagliptin. Dipeptidyl peptidase 4 inhibitors, the gliptins. They cause degrading of GLP-1, so glucagon-like peptide 1. So when glucagon-like peptide 1 is degraded, you'll get increased insulin secretion. DPP-4 usually degrades GLP-1, which glucagon-like peptide 1 increases insulin secretion. GLP-1 increases insulin secretion. So when you inhibit DPP-4, you increase GLP-1 and increase insulin secretion. Side effects of the gliptins, like DPP-4 inhibitors, are nausea and vomiting. So GLP-1 increases insulin secretion, so the glucagon-like peptide 1 analogs are exenatide and liraglutide. Exenatide, liraglutide. GLP-1 analogs, exenatide and liraglutide. GLP increases insulin secretion, slows intestinal absorption of glucose, and decreases glucagon. So up insulin, less glucose getting absorbed into the intestine, and less glucagon secretion. Now the GLP-1 analogs, exenatide and liraglutide, cause some side effects like pancreatitis, hypoglycemia, and weight loss. So meglinotides and GLP-1 analogs both cause hypoglycemia. But with GLP-1 analogs, exenatide and liraglutide, remember, pancreatitis and weight loss. So for both DPP-4 inhibitors like the gliptins and GLP-1 analogs like exenatide and liraglutide, they both delay gastric emptying. That's right. DPP-4 and GLP-1 delay gastric emptying. Another diabetes medication, pramlintide, is an amylin analog. Amylin is a pancreatic hormone. Amylin is secreted with insulin. Amylin decreases glucagon, and it also delays gastric emptying. So delayed gastric emptying is DPP-4 inhibitors, GLP-1 analogs, and pramlintide. And side effects are just nausea, vomiting, hypoglycemia. Also remember that amylin is released with insulin. And pramlintide can also cause weight loss. and decreased hemoglobin A1C. So pramlintide, the amylin analog, decreases hemoglobin A1C. Now for alpha-glucosidase inhibitors, acarbose and miglitol. What are they? Miglitol and acarbose. They just cause GI upset, blah, blah, blah. For TZDs, remember that they can cause liver damage, most notably troglitazone causes liver damage. Also, TZDs cause edema, and TZDs cause hypoglycemia. Also, pioglitazone causes weight gain, so weight gain and edema, thiazides. No, not thiazides, TZDs rather. Metformin. Metformin is a biguanide. Metformin causes lactic acidosis, so you do not give metformin if they have renal insufficiency. Look out for liver dysfunction, congestive heart failure, alcoholism, and sepsis. Liver, heart failure, alcoholism, and sepsis, they might cause renal insufficiency, which would be a contraindication for metformin because it causes lactic acidosis. But metformin does not cause hypoglycemia. Also, when a patient is undergoing radiology studies requiring iodinated contrast, you stop metformin because iodinated contrast might cause renal dysfunction. And so you would have renal dysfunction, so you'd not use metformin. It also causes GI upset, and metformin causes impaired absorption of vitamin B12 cobalamin. So metformin impairs cobalamin absorption. Metformin also causes weight loss. And you use metformin to treat polycystic ovarian syndrome. Metformin treats PCOS. When metformin is used to treat PCOS, it increases insulin sensitivity, decreases insulin levels, and this decreases testosterone, which enables LH surge. So metformin increases insulin sensitivity, decreases insulin levels, decreases testosterone, LH surge. Now for sulfonylureas, first generation chlorpramide, tolbutamide, tolazamide, second generation glyburide, glipizide, third generation glimepiride. So sulfonylureas stimulate insulin release from target tissues. They reduce serum glucagon levels because increased insulin will inhibit glucagon secretion. So sulfonylureas, you have lowered glucagon. Sulfonylurea side effects: hypoglycemia. Sulfonylureas also causes skin rash, and then first generation chlorpropamide, tolbutamide cause a disulfiram-like reaction. And also you should be cautious about renal or hepatic insufficiency with sulfonylureas. Just like metformin, if the patient is renal or hepatic insufficient, then you're careful about sulfonylureas. Also, if the woman is pregnant, you do not use sulfonylureas. So hepato or liver function or kidney function or pregnant, do not use sulfonylureas. More side effects of sulfonylureas: weight gain, decreased muscle mass, and decreased beta cells. So metformin causes weight loss, but sulfonylureas will cause weight gain. I think metformin is probably the only one that causes weight loss. Now for synthetic EPO. Synthetic erythropoietin, you're worried about patients with renal failure, just like with metformin and with sulfonylureas. So synthetic EPO is also a teratogen, and it causes hypertension. And synthetic EPO can lead to cardiovascular events and thrombotic complications with renal failure patients. This is especially if hemoglobin levels get over 13. Synthetic EPO is called epoetin and darbepoetin. What do you think when you see aminocaproic acid? That it inhibits tissue plasminogen activators. It's also called tranexamic acid. So it also inhibits fibrinolysis and inhibits plasminogen activation. So when you want to keep the clots going, aminocaproic acid. Side effects, though, you guessed it, thrombosis and hypotension. Aminocaproic acid can cause hypotension. So you would use aminocaproic acid, obviously, in bleeding with postnatal complications and with hemophilia. What are the three GP2B and 3A inhibitors? Well, one is obviously abciximab. The other two are, one begins with an E and one begins with a T. One is atide and one is fiban. Abciximab, eptifibatide, tirofiban. Eptifibatide, tirofiban, GP2B, 3A inhibitors, as well as abciximab. You use these for unstable angina and percutaneous coronary intervention, such as percutaneous transluminal coronary angioplasty. Once again, abciximab, eptifibatide, and tirofiban. And the toxicity that they cause are thrombocytopenia, diffuse alveolar hemorrhage, and bleeding. So remember, glycoprotein 2B3A inhibitors cause low platelets and diffuse alveolar hemorrhage. How do they work? GP2B3A inhibitors, abciximab, eptifibatide, and tirofiban. They bind the GP receptor 2B3A on activated platelets, preventing aggregation. You would also use these after placing a stent. Again, what are the side effects of abciximab, eptifibatide, and tirofiban? Thrombocytopenia, diffuse alveolar damage, and bleeding. Now for dipyridamole. Remember that this one is a little different from silastazole. It has two mechanisms. The first one is that it inhibits cyclic GMP phosphodiesterase, just like silastazole, increasing GMP and vasodilation, but it also inhibits uptake of adenosine into the platelets and endothelial cells. So when you have dipyridamole, you'll have increased blood adenosine because it's not going into the platelets. This increased levels of adenosine will activate platelet A2 receptors. A2 receptors on the platelets that are activated by adenosine will activate adenylate cyclase and increase levels of cyclic AMP. So you get increased GMP and AMP with dipyridamole. So when you have increased levels of cyclic AMP, that inhibits thromboxane A2 synthesis. Increased CAMP inhibits thromboxane, and it increases prostacyclin production. So this inhibits platelet aggregation and thrombus formation because there's no thromboxane and there's more prostacyclins. Dipyridamole. You use dipyridamole for cardiac stress tests. And its side effects are hepatotoxicity, hypotension, and GI upset. Dipyridamole is toxic to liver. Dipyridamole causes hypotension. This is probably because it increases adenosine, which causes vasodilation, I would guess. So that's dipyridamole causes hypotension and hepatotoxicity. When you use dipyridamole with aspirin, it prevents stroke. Okay. Silastazole. Actually, silastazole inhibits cyclic AMP phosphodiesterase. diestrase 3, cyclic AMP 3. So that would break so you would get increased cyclic AMP levels just like dipyridamole, but dipyridamole also increases cyclic GMP levels as well. So Celastazole, you get increased prostacyclines, decreased thromboxane A2, and then vasodilation, inhibited platelet aggregation, and inhibited thrombus formation. But the side effects for Celastazole, okay, first of all, it treats claudication symptoms in people with peripheral arterial disease. So claudication is like painful walking, so you'd use Celastazole for that. And side effects for Celastazole. It causes headache, palpitations, GI upset. So if you have a patient with congestive heart failure, that's a contraindication for Celastazole. Celastazole you do not use in patients with congestive heart failure. Why? Because Celastazole causes palpitations, and it also causes headache and GI upset. So remember, Celastazole is a direct arterial vasodilator. Celastazole dilates arteries, and it's superior to aspirin in treating peripheral arterial disease. What's another class of medications that you can use for acute coronary syndromes? Does the same thing as one of them is abciximab and eptifibatide and tirofiban, the GP2B3A inhibitors. But another thing is the ADP inhibitors. You can also use those for acute coronary syndromes. They are prasugrel, clopidogrel, ticlopidine, ticagrelor. They irreversibly block ADP receptors. Clopidogrel, ticlopidine, prasugrel, and ticagrelor irreversibly block ADP receptors, and they prevent fibrinogen to bind. They inhibit fibrinogen binding by preventing GP2B3A from binding to fibrinogen. So ADP receptors, fibrinogen can't bind to GP2B3A. You also use these in coronary stenting, and they reduce the incidence of thrombotic stroke. And you use them along with aspirins for percutaneous coronary interventions. Side effects of prasugrel, it's similar to abciximab and eptifibatide and tirofiban, which cause low platelets. It causes thrombocytopenia, but prasugrel causes thrombocytopenic purpura, TTP. Prasugrel causes TTP rarely. Prasugrel can also cause bleeding and allergic reaction. So you don't use prasugrel in patients with active bleeding or if they're above 75 years old or had a prior stroke. Remember that clopidogrel and prasugrel need to be activated by the CYP 450 enzymes to become active. So ADP receptor inhibitors need to be metabolized to become active. Also with clopidogrel, here's a side effect. In addition to thrombocytopenic purpura, which is also clopidine, clopidogrel can cause a neutropenia. Clopidogrel think neutropenia. Neutropenia think clopidogrel. Oh, how do you treat both aspirin toxicity and TCA toxicity? Sodium bicarbonate. It's just a side note. New medication. What do you use for prophylaxis against DVTs and thromboembolism in patients with atrial fibrillation? Factor 10 inhibitors, rivaroxaban, apixaban, betrixaban, direxaban. They directly inhibit factor 10A. So DVTs and atrial fibrillation thromboembolism, think factor 10 inhibitors. Side effects are bleeding, allergic reaction, and if the patient is allergic to heparin, then you'd use rivaroxaban. Keep in mind that rivaroxaban and factor 10 inhibitors increase increase PT and APTT, but not thrombin time. Now for direct thrombin inhibitors: hirudin, bivalirudin, lepirudin, desirudin, argatroban, melagatran, and dabigatran. Don't confuse these with tirofiban. Tirofiban is a GP2B3 or 2A3B or 2B3A inhibitor. Tirofiban. Do not confuse tirofiban with argatroban, melagatran, dabigatran, lepirudin, desirudin, bivalirudin, and hirudin. Direct thrombin inhibitors directly inhibit thrombin, and this interferes with both intrinsic and extrinsic coagulation cascade. So you use them for acute and chronic anticoagulation. For DVTs, acute coronary syndrome, and atrial fibrillation. So basically everything that you use for a factor 10 inhibitor, or an ADP receptor inhibitor, or a GP2B3A inhibitor, you can use direct thrombin inhibitors for the same things. DVTs, acute coronary syndrome, atrial fibrillation, coagulation. So bivalirudin, blah, blah, blah. Argatroban treats HIT, heparin-induced thrombocytopenia. Argatroban think that it treats HIT. HIT argatroban, HIT argatroban, argatroban HIT. Argatroban treats heparin-induced thrombocytopenia. Dabigatran is oral, and dabigatran especially treats atrial fibrillation in place of warfarin. Side effects of direct thrombin inhibitors: there aren't many, but anaphylaxis and bleeding. So both PT and PTT are increased with direct thrombin inhibitors, as well as factor 10 inhibitors. What does argatroban treat? Heparin-induced thrombocytopenia. What does antithrombin 3 do? It inhibits what? It inhibits what factor? Antithrombin 3 inhibits factor 10A, XA. Antithrombin 3 inhibits factor XA. This inhibits the coagulation cascade. So fondaparinux treats acute DVTs or pulmonary embolism. So pulmonary embolism, think you're treating that with heparins. Also DVTs with heparins. And it's DVT prophylaxis following orthopedic surgery. Think fondaparinux. Side effects are hepatotoxicity for fondaparinux. So the heparin fondaparinux is hepatotoxic. Oh, and just how argatroban treats heparin-induced thrombocytopenia, for fondaparinux you can still use fondaparinux with heparin-induced thrombocytopenia. So heparin, the drug, can also be used on top of DVTs and pulmonary embolism. You can also use it for acute myocardial infarction. And antithrombin 3 degrades several clotting factors, especially thrombin. So 2 and 10, but especially thrombin. And enoxaparin and dalteparin, they are low molecular weight forms of heparin, and they especially degrade factor 10, just like fondaparinux. And so enoxaparin and dalteparin have a longer duration of action than heparin. So less frequent dosing than heparin for enoxaparin and dalteparin. You only have to give enoxaparin and dalteparin, the low molecular weight forms of heparin, infrequently. Also, what are two natural anticoagulants? Think prostacyclin and nitric oxide. Prostacyclin inhibits platelet activity. Nitric oxide inhibits platelet adhesion and aggregation. And tissue plasminogen activator is released by damaged endothelial cells, and it converts plasminogen to plasmin, which degrades fibrin. Thrombomodulin activates protein C. Protein C binds protein S. And then C and S together degrade 5 and 8. Thrombomodulin activates C. C binds S. C and S degrades 5 and 8. Things that cause metabolic alkalosis. LVAH. Loop diuretics, vomiting, antacids, hyperaldosteronism. Metabolic alkalosis. Loop diuretics, vomiting, antacids, hyperaldosteronism. Now, what is nasiratide? Nasiratide is a BNP analog. What does BNP do to the preload and afterload? BNP reduces both preload and afterload because it relaxes smooth muscles with CGMP. BNP reduces preload and afterload. So it's used in acute decompensated heart failure, but it does not provide a benefit for mortality. So BNP causes hypotension. That's its main side effect. It also causes confusion and headache, dizziness, nausea, cardiac arrhythmias. Nasiratide, a BNP analog, causes confusion, headache, cardiac arrhythmias, hypotension especially. And if the patient does not have a systolic blood pressure of at least 90, you don't use nasiratide or BNP analog. So systolic blood pressure has to be at least 90. Now, what are the causes of respiratory alkalosis? So metabolic alkalosis was loop diuretics, vomiting, antacids, and hyperaldosteronism. But respiratory alkalosis is hyperventilation, salicylates, and pulmonary embolism. Pulmonary embolism, respiratory alkalosis. Also, tumors would cause respiratory alkalosis. So pulmonary embolism and tumors, respiratory alkalosis. Let's say you have a patient who's taking nitrates. What do you not use with nitrates? Sildenafil and vardenafil and tadalafil. You do not use them with nitrates because that could cause hypotension. Also, sildenafil side effects are headache, flushing, and impaired blue-green vision and dyspepsia. So sildenafil, it impairs your blue-green vision. Sildenafil impairs your blue-green vision. Milrinone. Milrinone is the same thing as amrinone. Milrinone inhibits phosphodiesterase 3 in cardiac and smooth muscle. When phosphodiesterase 3 is inhibited, you have increased CAMP, so this opens calcium channels on the surface of the cell. Calcium flows into the cell and increases contractility. And you also, with milrinone, you get increased contractility and decreased preload and decreased afterload. So you treat congestive heart failure or acute decompensated heart failure with milrinone. Milrinone, amrinone, increases contractility, decreases preload, and decreases afterload. Side effects of milrinone or amrinone are thrombocytopenia, cardiac arrhythmias, nausea, and vomiting. Thrombocytopenia, cardiac arrhythmias, nausea, and vomiting for milrinone. Remember that cyclic AMP in the heart increases the conductance of calcium channels in the sarcoplasmic reticulum. More calcium enters the cell. You get stronger contractions with milrinone. Now for a case-bearing diuretic. Triamterene or amiloride treats volume overload syndrome, diabetes insipidus, which is nephrotic diabetes insipidus, treated by case-bearing diuretic, triamterene, and amiloride. And you can also use it for heart failure, liver failure, and nephrotic syndrome when they cause volume overload. Also, like for Addison's disease, when the patients lack aldosterone, you could use triamterene or amiloride. Side effects of triamterene and amiloride, since it's a case-bearing diuretic, it's hyperkalemia. Also, metabolic acidosis and GI upset. So Case-bearing diuretics, metabolic acidosis. Case-bearing diuretics, metabolic acidosis. This makes sense because with hyperaldosteronism, you would get metabolic alkalosis. So with case-bearing diuretics, you get metabolic acidosis. Oh, and triamterene amiloride also treats Little syndrome. Little syndrome, which is dominant, causes metabolic alkalosis. So you would treat it with triamterene amiloride, which side effect is metabolic acidosis. Now for spironolactone. Spironolactone is a competitive aldosterone receptor antagonist. Spironolactone treats primary hyperaldosteronism, volume overload syndromes associated with heart failure, liver failure, nephrotic syndrome, and hypertension. Also, spironolactone treats female hirsutism associated with PCOS. So PCOS, spironolactone. Why? Because spironolactone causes gynecomastia in males, so it would do the reverse for females. It would decrease their hair. You also get metabolic acidosis because it's a case-bearing diuretic, and hyperkalemia and GI upset. Eplerenone, on the other hand, does not have any androgen effects. So with eplerenone, another case-bearing diuretic, you do not get gynecomastia, same with spironolactone. So eplerenone does not cause that. Yeah. Okay, now for thiazides, what's something that you didn't know that thiazides treat? Recurrent kidney calcium stones. So since thiazides are calcium sparing, they would reabsorb the calcium that would normally form a stone in the kidney ducts. Also, hyperuricemia, metabolic alkalosis. Thiazides and loop diuretics both cause metabolic alkalosis. Now for loop diuretics, they get rid of calcium, and so they treat hypercalcemia and hypertension. They don't cause hypercalcemia like the other ones, okay? Or like the thiazides. Okay, side effects of furosemide are hypokalemia, metabolic alkalosis, because it's a loop diuretic, autotoxicity, yeah, you knew that, hypovolemia, interstitial nephritis. So loop diuretics are nephrotoxic. Also hyperuricemia, you knew that, gouty attacks, hypomagnesemia for loop diuretics. And because it and thiazides are sulfa drugs, then it causes sulfa allergy. So if you have a sulfa allergy and you need a loop diuretic, what medication do you use? Ethocrinic acid. Ethocrinic acid is a loop diuretic that's not a sulfonamide. Also, ethocrinic acid causes less hyperuricemia than furosemide. So if you're worried about sulfa allergies or hyperuricemia, you'd use ethocrinic acid. But ethocrinic acid still does cause hyperuricemia. So you would never use it to treat gout, obviously. So it still causes hyperuricemia. And remember that both thiazides and loop diuretics can cause what? Pancreatitis. Pancreatitis can be caused by loop diuretics and thiazides. Which diuretic is nephrotoxic? Furosemide, the loop diuretics, is nephrotoxic. Also remember that furosemide can cause dehydration. Also remember that if you have increased plasma protein concentration, what will happen to the GFR? It will decrease. So high protein, low GFR. What does diabetic glomerulonephropathy do to the GFR? Diabetic glomerulonephropathy increases GFR. Acetazolamide, the carbonic anhydrase inhibitor, causes hyperchloremic metabolic acidosis because it is... acetazolamide causes a hyperchloremic metabolic acidosis because it's part of the hard ass mnemonic, hyperalimentation, Addison disease, renal tubular acidosis, diarrhea, acetazolamide, spironolactone, saline infusion. So spironolactone, the K-sparing diuretic, and acetazolamide, the proximal tubular diuretic, both cause metabolic acidosis, hyperchloremic metabolic acidosis. But while acetazolamide causes hypokalemia, the K-sparing diuretics cause hyperkalemia. So that's the difference between the two. They both cause metabolic acidosis, but acetazolamide will cause low K. Acetazolamide is also causes sedation, neuropathy, and it can cause allergic reaction because it's a sulfa drug. Remember that acetazolamide causes the urine to have increased sodium, potassium, calcium, and bicarbonate in the urine. Bicarbonate, calcium, potassium, and sodium in the urine, acetazolamide. Acetazolamide, also dorzolamide and brenzolamide. Brenzolamide, dorzolamide, acetazolamide. Acetazolamide also treats glaucoma. And so what does it do to the urine? Because acetazolamide causes metabolic acidosis, it alkalinizes the urine. So if you have ingestion of salicylate or barbiturates, acetazolamide will cause salicylates and barbiturates to precipitate in the urine because it causes the urine to be what? Alkalinic. Acetazolamide also decreases CSF production, and it works in the eyes to treat glaucoma. And it's an adjunct treatment for epilepsy. Acetazolamide side effects might be described as somnolence and paresthesias. Acetazolamide side effects might be described as somnolence and paresthesias. Remember that in glaucoma, it's the ciliary epithelium that secretes aqueous humor. So acetazolamide and timolol. Timolol is the beta blocker. They both decrease secretion in the ciliary epithelium. Other drugs that treat glaucoma, think F2A prostaglandins and cholinomimetics. So the other things that treat glaucoma are prostaglandin F2A, which is latanoprost, uniprostone, and travoprost. The main one is latanoprost, treats glaucoma. And cholinomimetics are pilocarpine and carbachol. They decrease the outflow of aqueous humor. Think prostaglandins, cholinomimetics. Think latanoprost, uniprostone, travoprost, pilocarpine, carbachol. Decrease intraocular pressure. Remember, timolol, betaxolol, and cartilol, they're beta blockers that treat glaucoma. Timolol, betaxolol, and cartilolol. So while you'd use beta blockers for glaucoma, you can also use alpha agonists. Beta blockers, alpha agonists. Alpha agonists that you'd use are epinephrine and brimonidine, which is alpha 2 agonist. Epinephrine and brimonidine, alpha 2 agonist. They decrease aqueous humor synthesis by vasoconstriction, or brimonidine just decreases aqueous humor synthesis. When you're using alpha agonists to treat glaucoma, the side effects are mydriasis, so you don't use this in closed-angle glaucoma. Alpha agonists do not treat what? What kind of glaucoma do closed-angle glaucoma do not treat with what? Alpha agonists. And they cause mydriasis. In blurry vision, so alpha agonists cause blurry vision, ocular hyperemia, foreign body sensation, ocular allergic reactions, and ocular pruritus. So if you see a foreign body sensation in the eye, you're probably being treated with an alpha agonist glaucoma drug. Now for the side effects of cholinomimetics. So the direct ones were pilocarpine and carbachol, Indirect cholinomimetics are physostigmine and ecothiopate. They increase outflow of aqueous humor via contraction of ciliary muscle and opening of trabecular meshwork. So pilocarpine is for emergencies, and it opens the meshwork into the canal of Schlemm. So think parasympathetic treatments for glaucoma, that they increase the aqueous humor, and they contract the ciliary muscle, opening the trabecular meshwork. And side effects of cholinomimetics are the opposite of the alpha agonists. Cholinomimetics cause meiosis and cyclospasm, which is contraction of ciliary muscle. And so for prostaglandins, you use them to treat glaucoma, latanoprost, PGF2A. Remember that increases the outflow of aqueous humor. So both cholinomimetics, like pilocarpine, carbachol, physostigmine, ecothiopate, and prostaglandins, latanoprost, increase outflow of aqueous humor. And latanoprost side effect is it darkens the color of the iris. It browns the iris. Latanoprost side effect darkens the color of the iris. Okay, back to acetazolamide. Acetazolamide actually, since it's calcium wasting, you get calcium stone formation in the renal tubules. This is calcium oxalate because remember, acetazolamide causes metabolic acidosis, alkalinizes the urine, so anything that's acidic, like an acidic stone, like calcium oxalate, would precipitate. So you get also, it'll cause the bone to increase release of calcium phosphate. So, calcium stones caused by acetazolamide. Calcium oxalate stones, because the urine is alkaline, so the acid stones would precipitate. Mannitol. Other osmotic diuretics are urea, glycerin, and isosorbide. Mannitol, urea, glycerin, isosorbide. Mannitol treats intracranial and intraocular pressure by volume depletion. So mannitol could maybe also be used to treat glaucoma. Mannitol also treats acute renal failure and prevents development of acute renal failure following toxin exposure, trauma, or shock. So if you have renal failure caused by toxins, trauma, or shock, mannitol might be a treatment for that. Side effects of mannitol: pulmonary edema, GI upset, headache, and dehydration. Headache, mannitol. Pulmonary edema, mannitol. Mannitol causes pulmonary edema, side effect. Watch out for pulmonary edema if you're using an osmotic diuretic called mannitol. Also, if you have a patient with congestive heart failure can lead to pulmonary edema, so you don't use mannitol if you have congestive heart failure because it can lead to pulmonary edema. Also, anuria. So mannitol increases urine production, but if you are anuric, so you're not producing NUP, then you do not use mannitol. And isosorbide and glycerin are only used for eyes. Isosorbide and glycerin are only used for ophthalmic procedures. Isosorbide and glycerin are only used for ophthalmic procedures. The effect of mannitol is to increase urine outflow and decrease effective circulating volume in the body. Now for calcium channel blockers. What voltage-gated calcium channel type do they act on? L-type. Calcium channel blockers decrease myocardial contractility. Calcium channel blockers decrease cardiac contractility. So, verapamil and diltiazem, what's special about them? What do they treat? So, it's a 4-acronym letter word that verapamil and diltiazem treat. PSVTs, or supraventricular tachycardias. Verapamil and diltiazem. What else do calcium channel blockers treat? Hypertension, Prinzmetal angina, and Raynaud disease. So hypertension, Raynaud disease, and what? Prinzmetal angina. What do you treat with them? Calcium channel blockers. Hypertension, treat with calcium channel blockers. What are the side effects of verapamil and diltiazem? There are two of them, two main ones, two special ones. Bradycardia and heart block. So verapamil and diltiazem will slow down the heart so much that it will cause bradycardia and heart block. Calcium channel blockers also produce hypotension, peripheral edema. That's amlodipine. Amlodipine, peripheral edema. Amlodipine, peripheral edema. If the patient has decreased ejection fraction, what are you worried about? Are you worried about using calcium channel blockers for decreased ejection fraction because of negative ionotropic effects of calcium channel blockers? So verapamil and diltiazem are mostly on cardiac tissue. Nifedipine, nicardipine, and amlodipine are mostly on vascular smooth muscle tissue. So nifedipine, which you treat subarachnoid hemorrhage with, nicardipine and amlodipine are mostly on vascular smooth muscle, where verapamil and diltiazem are the cardiac ones. So a patient has second-degree cardiac block, what medication has been used? Either verapamil or diltiazem. Remember, the dihydropyridine calcium channel blockers are the ones that are in the peripheral vasculature, so not diltiazem and verapamil. The dihydropyridine ones are nifedipine, nicardipine, and amlodipine are the dihydropyridine ones. And the dihydropyridine ones and the peripheral ones cause reflex tachycardia. So they should not be used for patients with acute coronary syndrome because oxygen consumption in the myocardium increases reflex tachycardia. So peripheral edema, think reflex tachycardia. Because you're not really blocking the heart muscle ones, you get reflex tachycardia. Verapamil and diltiazem can also cause two other side effects: constipation and gingival hyperplasia. So amlodipine, think flushing and peripheral edema, amlodipine. Also for nifedipine, it blocks calcium influx in the bronchial smooth muscle cells, so nifedipine can cause bronchodilation. Nifedipine can cause bronchodilation. Verapamil and diltiazem increase lithium concentration, but the other calcium channel blockers do not. So verapamil and diltiazem increase lithium concentration. Other things that increase lithium concentration are NSAIDs, thiazide diuretics, and ACE inhibitors. So increased lithium concentration are the same things that reabsorb sodium in the proximal tubule. So think NSAIDs, thiazides, and ACE inhibitors. Which calcium channel blockers increase lithium levels? Verapamil and diltiazem. Nifedipine increases bronchodilation. So verapamil and diltiazem were previously the drug of choice for PSVT, but now that drug is adenosine. Adenosine is the #1 treatment for PSVT. Now remember that verapamil, calcium blockers 2 and beta blockers, calcium blockers 4 and beta blockers 2 are rate control, so they increase PR. Class 2 and class 4 increase PR. They do not increase QT. So while you could use class 4 for PSVT, you would never use class 4 for ventricular tachycardia, VT. So that's a no-go. Class 4, never use it for VT. For what class 4 treats, mainly just think hypertension, angina, Raynaud disease. More adverse effects of calcium channel blockers, think negative ionotropy and the potential for AV block. Calcium blockers may cause AV block. So for nifedipine and the dihydropyridine calcium channel blockers, not diltiazem and verapamil, the other ones, the nifedipine ones, they would cause a reflex increase in heart rate. So verapamil and diltiazem increased PR. Verapamil and diltiazem increased PR. Another thing that verapamil and diltiazem do is they increase coronary blood flow and reduce myocardial oxygen demand. So that masks ischemia during stress testing. Once again, verapamil and diltiazem increase coronary blood flow, and they also reduce myocardial oxygen demand. So that masks ischemia during stress testing. So to sum it all up, class 4 also treats something else. So besides supraventricular tachycardia and like all those Prinz metals, angina, and hypertension, it also treats atrial fibrillation. That's right. Class 4 treats atrial fibrillation. And since verapamil and diltiazem cause vascular smooth muscle relaxation in the heart, they treat hypertension and angina. Watch out for hypotension with class 4. Hypotension is a side effect of class 4. Now for hydralazine. What does hydralazine do? It dilates what? Hydralazine dilates arteries. Hydralazine dilates arteries. Hydralazine causes reflex tachycardia, and it dilates arteries. So you would use hydralazine with a beta blocker to avoid tachycardia, to avoid the reflex tachycardia. Hydralazine dilates arteries. Hydralazine, what does it treat? Hypertension and heart failure by reducing afterload. So afterload would be what's associated with arteries. So hydralazine decreases afterload. And hypertension in pregnancy, you would use hydralazine as well as methyl-dopa. So hydralazine and methyl-dopa in hypertension in pregnancy, so eclampsia, preeclampsia. Side effects of hydralazine. Think 1, 2, 3, 4, 5. So like 5 or 6 things. But the most important one is lupus. Hydralazine causes lupus. Hydralazine also causes fluid retention and edema. This is probably when the arteries vasodilate, then fluid leaks and causes edema. Hydralazine also causes hypotension. This is pretty logical. Hydralazine causes headache and reflex tachycardia. So that may provoke angina. It may provoke angina. So hydralazine causes both SLE-like syndrome and lupus. And lupus, SLE-like syndrome. Drug-induced lupus. So, quick diversion. Congestive heart failure, what do you treat that with? ACE inhibitors and beta blockers, but if it's acute decompensated, you do not use beta blockers. So ACE inhibitors, beta blockers, angiotensin II receptor blockers, and spironolactone, also thiazides or loop diuretics, and hydralazine with nitrate therapy decreases mortality. Hydralazine, nitrate, spironolactone, ACE inhibitors, beta blockers, angiotensin receptor blockers, thiazide, and loop diuretics. So if the patient has coronary artery disease or angina, do not use hydralazine. So hypertension in pregnancy, what do you treat that with? Methyl-dopa hydralazine and labetalol and nifedipine. Labetalol and nifedipine, and hydralazine and methyl-dopa. Also, you'll need to prevent seizures, so you use magnesium sulfate in preeclampsia and eclampsia. So if you see antihistone antibodies, think that it's drug-induced SLE. Could be caused by hydralazine, isoniazid, phenytoin, and procainamide. So that's a vasodilator, like an arterial vasodilator, and procainamide, which is class 1A, it can cause antihistone antibodies. Also could be chlorpromazine and quinidine for drug-induced lupus. Antihistone antibodies. Hydralazine increases cyclic GMP. And another side note, so hydralazine actually, for as far as the kidneys go, it doesn't improve renal perfusion. So hydralazine, it's an arterial vasodilator, but it does not improve renal perfusion. Another quick connection for the what causes drug-induced SLE. So that is caused by N-acetylation in the liver. So drugs that undergo N-acetylation in the liver cause SLE. Hydralazine, procainamide, isoniazid, chlorpromazine, methyl-dopa, and quinidine. And this drug-induced lupus could especially happen in slow acetylators. So if they're genetically predisposed to be slow acetylators, then they would cause drug-induced lupus. And minocycline is another drug that can cause drug-induced lupus. Minocycline. Drug-induced lupus, minocycline. Don't confuse minocycline with minoxidil, which is like hydralazine. Minoxidil is like hydralazine. It dilates arterial smooth muscle by opening potassium channels. So that's a different mechanism for minoxidil. While hydralazine is cyclic GMP channels, minoxidil is dilates arterial smooth muscle by opening potassium channels and hyperpolarizing the myocyte. So, and inhibiting smooth muscle contraction. So the potassium goes in, depolarizes the cell relaxes. Minoxidil, the cell relaxes. It's an hypertensive, treats refractory hypertension. Minoxidil side effect is hair growth. So minoxidil is Rogaine and promotes hair growth when used topically. Some quick anti-diabetes medications, canagliflozin and dapagliflozin. So gliflozin, remember they inhibit SGLT2 channels, which resorb glucose in the proximal tubule. So canagliflozin and dapagliflozin, you'll lose glucose in the urine. And you should monitor serum creatine before and after SGLT2 inhibitors. So gliflozin, remember, monitor creatine, and that treats diabetes. Gliflozin, SGLT2 inhibitors, monitor creatine before. Also monitor BUN levels before gliflozins. Now for class 3 antiarrhythmic agents, it's a big topic. So remember, they are sotalol, ibutylide, dofetilide, amiodarone, and bretylium. Remember, they all prolong the QT. They have no effect on QRS. Sotalol also blocks beta blockers. Okay, so prolonged QT, no effect on QRS. What do you use only for atrial arrhythmias? Dofetilide and ibutylide. Only atrial arrhythmias for dofetilide and ibutylide. Sotalol and amiodarone you can use for anything basically. So those are your mainstay ones. And then bretylium is emergency treatment for ventricular. So atrial, think dofetilide and ibutylide. Ventricular, think bretylium. But for both, think sotalol and amiodarone. Amiodarone treats ventricular fibrillation, atrial and ventricular arrhythmias, and supraventricular arrhythmias or tachycardias. So, side effects. All class 3 can cause cardiac arrhythmias, all class 3 can cause torsade de pointes. Class 3 can slow the heart rate. Class 3 can slow the heart rate and cause bradycardia and hypotension. Now for amiodarone side effects. Think thyroid. It can usually cause hypothyroidism, but it can also cause hyperthyroidism. But usually think hypothyroidism for amiodarone. Amiodarone has also skin effects. If you see blue-gray skin or photodermatitis, think amiodarone. Also causes pulmonary fibrosis and it's hepatotoxic, and because it inhibits P450 enzymes, it interacts with warfarin. And also think eyes, think corneal deposits, amiodarone, eyes, skin, pulmonary fibrosis, and hypothyroidism. Amiodarone is special because it's all classes. It blocks sodium, potassium, and calcium channels on cardiac myocytes. And it's kind of an alpha and beta blocker as well. And let's see. So think mainly hepatotoxicity, thyroid dysfunction, pulmonary fibrosis, ataxia, cardiac arrhythmias, and photosensitivity. Dofetilide and ibutylide, atrial arrhythmias. Amiodarone and sotalol, ventricular fibrillation, atrial and ventricular tachycardias, arrhythmias. Now for adenosine. With adenosine, remember that dipyridamole, it has two mechanisms. One of the mechanisms is it blocks the uptake of adenosine, so there will be interaction. Dipyridamole will intensify the effects of adenosine. So when you're using adenosine, watch out for dipyridamole. Also, another thing, caffeine and theophylline inhibit adenosine receptors, so they'll decrease. Caffeine and theophylline will decrease the effectiveness of adenosine. Adenosine has a really short half-life. What does adenosine treat? Adenosine treats supraventricular tachycardia, so adenosine, think SVT, and also is used in cardiac stress testing. Dipyridamole is also used in pharmacological cardiac stress tests, so watch out for adenosine with that. Other side effects of adenosine are flushing, dyspnea, hypotension, and heart block. Adenosine can cause heart block and bradycardia, and adenosine can cause dyspnea. So dyspnea, hypotension, heart block, flushing, bradycardia, slow heart rate, and heart block for adenosine. What is the mechanism of adenosine? It increases potassium efflux. This hyperpolarizes the cell and decreases the frequency of cellular activation. So the cells will be hyperpolarized and they'll not want to fire as much. The heart will slow down because adenosine is blocking the potassium efflux of the. No, it's increasing the potassium efflux of the cell, making it slow down. Another side effect of adenosine, if you get like a heart burn, that is caused by bronchospasm or chest burning, bronchospasm, flushing, and high-grade block. Think adenosine. Remember, adenosine is paroxysmal supraventricular tachycardia, not ventricular tachycardia. Adenosine, like digoxin, slows down the conduction through the AV node, but it works by a different mechanism. And think hypotension because adenosine is a vasodilator. Adenosine does not work on the ventricles, it only works on the AV node and atria. Adenosine reduces the rate of spontaneous depolarization in the sinus node. Side note, cladribine, which treats hairy cell leukemia, is an adenosine analog. A little biochem purine salvage, adenosine is degraded to inosine by adenosine deaminase. It can also be converted to adenylic acid AMP. Adenosine can cause cutaneous flushing. Now for potassium. Potassium can cause hyperkalemia, cardiac arrhythmias, paralysis, and shock. So what does potassium do? It increases extracellular concentration of potassium. This makes it difficult for an action potential to be generated, so the rate of cardiac myocyte excitation is reduced, so it slows down the heart. Just like adenosine. Potassium is kind of like adenosine in that way. And potassium suppresses ectopic pacemakers. especially digoxin toxicity. So you treat digoxin toxicity with potassium. Now for magnesium. Magnesium side effects: paralysis, delayed deep tendon reflexes, hypotension, and hypermagnesemia. So the one that potassium has in common with magnesium is they both cause paralysis. And magnesium treats two things: torsade de pointes and digoxin toxicity. So potassium treats digoxin toxicity, so does magnesium. Magnesium also treats torsade de pointes. Now for class 1A, quinidine, procainamide, and diisopyramide. Class 1A slows down phase 1 depolarization and phase 3 repolarization. So there's a longer, so class 1A prolongs QT. Class 1A prolongs QT. Class 1A treats atrial fibrillation. So just how like sotalol and amiodarone can treat atrial arrhythmias, class 1A treats atrial fibrillation. And class 1A treats Wolff-Parkinson-White and ventricular tachycardia. So it's actually like, yeah, it's a lot like sotalol and amiodarone from class 3. Class 1A treats atrial fibrillation, ventricular tachycardia, and Wolff-Parkinson-White syndrome. Class 1A treats 3 things. Class 1A can cause torsade de pointes. And how would you treat torsade de pointes? Magnesium. You know that quinidine causes cinchonem, vertigo, headache, tinnitus, and psychosis, but procainamide causes drug-induced lupus and psychosis. Procainamide, lupus, and psychosis. Diisopyramide causes urinary retention, double vision, and constipation. So quinidine is like vertigo and hearing loss. Diisopyramide, think eyes, double vision, and urinary retention and constipation. Diisopyramide, 3 important things. What are they? One is bladder, one is vision, and one is GI. Constipation, double vision, urinary retention. Diisopyramide. And what does procainamide cause? Drug-induced lupus and psychosis. Now for class 1B, lidocaine, tocainide, and mexiletin, Mexican lettuce. Class 1B, they shrink the QRS. What does class 1B treat? Ventricular fibrillation or ventricular tachycardia. So while the 1A can treat ventricular tachycardia as well, 1A also treats atrial fibrillation and Wolff-Parkinson-White. Class 1B treats just ventricular stuff, ventricular fibrillation and ventricular tachycardia. Side effects of 1B are hypotension, tremor, fatigue, and nausea. And lidocaine can cause neurotoxicity and altered mental status. Now for the class 1C, flecainide, encainide, and propafenone. Propafenone is 1C, so is flecainide and encainide. Remember, they make just the QRS bigger, and they treat supraventricular arrhythmias. So class 1A treats basically everything. Class 1B treats just ventricular fibrillation or ventricular tachycardia. And class 1C treats supraventricular, SVT. Big contraindication for 1C, flecainide, encainide, and propafenone. If the patient has a decreased ejection fraction or coronary artery disease, you do not use 1C. So flecainide, encainide, and propafenone if patient has what 2 things? Coronary artery disease or lowered ejection fraction. That's a no-go for class 1C. Now for angiotensin receptor blockers: losartan, valsartan, candesartan, eprosartan, irbesartan, and telmirsartan. What do angiotensin receptor blockers do? They decrease peripheral resistance. Remember, with ARBs, you'll have decreased circulating volume of fluid in the body and decreased peripheral vascular resistance. ARBs are used to treat hypertension, congestive heart failure, and treat and prevent diabetic nephropathy. Side effects of ARBs are hyperkalemia because they would decrease aldosterone, which would normally lose potassium. And ARBs can also cause renal failure in renally insufficient patients. So ARBs, think a little bit of nephrotoxicity if they're renally insufficient. And ARBs cause hypotension, and ARBs are a teratogen. ARBs, just like ACE inhibitors, can cause fetal renal damage if used during pregnancy. ARBs also cause a rash. So think ARBs and ACE inhibitors, renal damage in fetuses and renally insufficient. What do ARBs and ACE inhibitors do to the preload? They decrease it. What about the afterload? They also decrease it. ACE inhibitors and ARBs decrease both the preload and afterload. Now for ACE inhibitors. Remember the catch mnemonic. What is that? Cough, angioedema, teratogen, increased creatine, increased potassium, so hyperkalemia and hypotension. ACE inhibitors treat hypertension and congestive heart failure. Also prevent diabetic nephropathy. Again, watch out for the fetal renal damage if used during pregnancy. Now for digoxin. Digoxin inhibits NAKTPase, so that decreases activity of the sodium-calcium exchanger. So with digoxin, remember, you'll get lots of intracellular calcium, so you'll get increased contractility of the cardiac myocyte. So digoxin, increased calcium, increased contractility, increased parasympathetic outflow at the sinoatrial node, so decreased heart rate. Increased contractility, decreased heart rate. Digoxin slows the AV conduction. So what do you what do you treat with digoxin? Atrial fibrillation. It's a second-line drug for atrial fibrillation. Digoxin is the second-line drug for atrial fibrillation. And you treat left ventricular heart failure with digoxin. So two things. Think atrial fibrillation and left ventricular heart failure. So a patient has anorexia, fatigue, confusion, weakness, delirium, abdominal pain, blurry yellow vision, so it's color vision changes, a prolonged PR interval, a decreased QT interval, ST segment scooping, T wave inversion, ventricular arrhythmia, AV block, hyperkalemia, nausea, vomiting, diarrhea. That's digoxin side effects. Digoxin. So just like how class 2 and class 4 will prolong the PR interval, so will digoxin. Digoxin is special because it decreases the QT interval. So digoxin causes hyperkalemia, but if you have hypokalemia, then it causes digoxin toxicity. And what do you get when you have this digoxin toxicity caused by hypokalemia? Renal failure. Also remember, digoxin fights with quinidine. Digoxin fights with quinidine for albumin binding sites. So you'll elevate digoxin levels if you use quinidine with digoxin. If you have digoxin toxicity, use insulin to decrease levels of potassium. So once again, for the side effects of digoxin: blurry yellow vision digoxin, anorexia digoxin, fatigue digoxin, confusion digoxin, weakness digoxin, delirium digoxin, abdominal pain digoxin, AV block digoxin, hyperkalemia digoxin, nausea, vomiting, diarrhea digoxin, increased PR, decreased QT, ST segment scooping digoxin, T-wave inversion digoxin, and digoxin can also cause ventricular arrhythmias. So it treats atrial fibrillation and it treats left ventricular heart failure, but digoxin can cause ventricular arrhythmias. What are the side effects of nitroprusside? Cyanide toxicity, orthostatic hypotension, metabolic acidosis, and arrhythmias. What are the side effects of nitroprusside? Metabolic acidosis, orthostatic hypotension, arrhythmias, and cyanide toxicity. So that was nitroprusside. What about nitroglycerin? What are the side effects of nitroglycerin? Transient compensatory tachycardia, headache, and orthostatic hypotension. So anything that's nitric oxide producing, think orthostatic hypotension. Nitroglycerin is given as isosorbide dinitrate, isosorbide mononitrate, and amyl nitrite. Nitroprusside, on the other hand, is just directly metabolized into nitric oxide in the bloodstream. Nitroprusside and nitroglycerin decrease both the preload and the afterload. For optimizing preload, when you think diuretics, what kinds of diuretics optimize the preload? Loop diuretics and calcium-sparing diuretics optimize the preload. Loop and potassium-sparing.